Good morning and welcome everyone to day 2 of CSCLA's Health Equity Summit. My name is Mayra Serrano, my pronouns are she, ella, and I'm going to be your host for today. We're excited to bring you an incredible series of presentations led by national experts in public health, behavioral health, and oncology who will shine a light on intersectionality in cancer care. Today, we will be hearing our keynote from Kate Hightshoe, Assistant Vice President and Diversity Officer for QCR Holdings on diversity, equity, and inclusion, as well as CE credit presentations from Lisl Schweers, lead psychosocial clinician for the Life Cancer Survivorship and Transition Service in the Cancer and Blood Disease Institute at Children's Hospital, Los Angeles. Dr. Scout also will be presenting a CE credit presentation. Dr. Scout is the Executive Director of the National LGBT Cancer Network. And also we're welcoming back Dr. Shannon Cava with the Cancer Support Community Los Angeles. There will also be a roundtable discussion this afternoon featuring Yolanda, Whittington with Sister Friends, Women's Counseling and Elder Care Management, Dr. Kauser, Ahmed with Sims-Man UCLA Center for Integrative Oncology, and Rocha with Providence St. John's Cancer Institute. Before we begin, I'd like to briefly go over some housekeeping items. Please note that we cannot see or hear you. Your video and microphone are automatically disabled for this webinar. We have disabled the chat room except for during the first 15 minutes of each presentation. And you can please direct all questions to the Q&A feature found in the Zoom navigation bar. Questions posed via the Q&A will be answered at the end of each presentation. We may not be able to get to all of your questions today, but we will do our best. For those of you who have registered to receive CE credits, we ask that you please keep an eye on the chat room for attendance instructions. The chat will be open for the first 15 minutes of each CE presentation for attendance purposes only. Post-event, you will receive an email from Connie Vore with a link to complete an evaluation for each presentation attended. You will need to complete the evaluation for any or all of the presentations you attend in order to receive a certificate. If you don't see this in your inbox, we ask that you please check your spam folder. If you have any questions regarding CE credits, you can please email info@cancersupportla.org. And now I'd like to introduce Julia Forth, CEO of Cancer Support Community Los Angeles, who will tell you a little bit more about CSCLA and the drive behind today's Health Equity Summit. Welcome, Julia.
Thank you, Mayra. And welcome, everybody. It's really a pleasure to welcome you to our second day of our Health Equity Summit. As Mayra said, I'm Julia Forth. My pronouns are she and her. And before we get started, I just want to tell you a little bit about the Cancer Support Community Los Angeles, and also to thank our incredibly generous sponsors of this event. Thank you to Kite, a Gilead company, Grow at Annenberg, UCLA Health, Johnson Comprehensive Cancer Center, Walgreens, Cedars-Sinai Cancer, and CGen. Thank you so much for your support of this important event. The Cancer Support Community Los Angeles provides free of charge psychosocial support to all patients and their families, caregivers, and loved ones. Our services include support groups and counseling, healthy lifestyle classes, child, teen, and family programs, education and social programs, and research and advocacy. And I'd also like to take this moment to thank all of our incredible clinicians, our facilitators, our volunteers, and the doctors and other professionals who help us with our educational program. Before we really get started, I'd like to invite you to watch this short video about our organization. Thank you.
Our immense thanks to Cancer Support Community. We know that your motto is, so no one faces cancer alone. boy, do I know what you mean by that.
Being diagnosed with cancer is one of the most difficult things that a person and their family can go through. The spirit of the mission of Cancer Support Community is that no one should face cancer alone.
When you come through the doors here, it is the most welcoming setting. It's like coming into a friend's home. And you don't have the feeling that you're going someplace because you're sick. You're going someplace to be with your friends. And that's what it's all about.
My father's name was Harold Benjamin, and he was the founder, along with my mother, Harriet Benjamin, of the Cancer Support Community, previously called the Wellness Community. Mom got cancer, and they realized that actually going to support groups made such a difference in her recovery. So my father decided that he would create this organization that would really make a difference in the lives of people with cancer and their loved ones. Gilda Radner came to the organization. She was so excited about how this changed her life. When Gilda passed, Gene Wilder and a woman by the name of Joanna Bull decided to start Gilda's Club in New York City. Several years ago, the Wellness Community and Gilda's Club joined forces.
We are a community, and we sustain each other through community. Aside from the services that we give, this is a very important gathering place of hope and support for people.
We laugh a lot in the groups, we cry a lot in the groups. I've made incredible lifelong friends.
I did not know that I was going to live. And I met someone in the group who had been alive for 7 years. Same tumor grade, same location, and had been alive for 7 years and had 2 little kids. And I needed the imagination to know that I could survive because I was so certain I wasn't going to.
When I got the news, I think I was a month, and it got really challenging having to break the news to my family because I didn't know how they would take it.
Until we are able to get rid of this disease once and for all, it's nice to know there's a lot of support to help you get through it.
The people that I've met here, I will be friends with for the rest of my life. The things that you can talk about are very personal. It's a safe place. When you get in a group, you realize that your problems really aren't that bad.
I would not be here today if it wasn't for CSC.
We had cancer. It is true that he was the one who was having the treatment and the existential experience. But in my way, I did too.
I finally broke down and decided to come into a walk-in group. You can't talk to your own friends in the same way because they really don't understand. I need as much help as Linda in a different way, that's all.
I passionately believe that the cure to cancer is not just the medications and the treatment that they give you. And what we found in the support center here is this amazing experience of being able to come here, find all those other things that make it a holistic treatment.
We have 5 pillars of support: groups and counseling, healthy lifestyle classes, educational workshops, social activities, and child, teen, and family programs. All of those pillars work together to create a holistic way of supporting not just the patient, but the family members.
We have calendars that show all the events and classes here. I've taken advantage of the group therapy, one-on-one, yoga, the lunch and learn workshops, educational things here.
No matter how I'm feeling, I pretty much always drag myself on Wednesdays to the writing group. It's a really amazing, supportive community, and it's really neat because it's one of the groups here at the Benjamin Center that can be combined of both caregivers and patients, which has really helped me to understand my partner's perspective through this, hearing some of the caregivers writing.
I walk through these doors and there's people, Zumba music dancing and people smiling and having fun.
I have discovered the celebration circle. That's a wonderful time just to get together and
think about the good things that are going on in your life and to express gratitude and not so much dealing with the cancer all the time. And it's a time to sort of fellowship over good food and good conversation and really having a time of just celebrating the life that we have.
I think that once people find out about this community, I'm hoping that they will be generous with their donation, because everything for the patients here and for the families is free. And we depend on the generosity of people who have the means to give back.
What you do more than any organization in the world is you give a sense of hope. Even if it's just one more day, one more week, one more month.
We really appreciate your donations. We appreciate your concern and commitment to this organization.
I think that's the true definition of love, when you can love someone or do something for someone that you don't know. Thank you.
I just want to say thank you, because it has given me like a family, and being able to connect and meet such amazing people like that in this space is just such a gift. Like, you're really giving people a gift by your donations.
Now that I've gotten through what I hope is the worst of it, I can look back and say that the cancer support community was one of the joys that this experience has brought to my life. So thank you for allowing me to have that experience, for giving me another place I can call home.
Well, let me take a moment to recover from that emotional and touching video, and I hope you all felt the same way. And now I want to get started with our keynote speaker for this morning. I'd like to introduce you all to Kate Hightshoe. She is creating a human experience for all people. Deeply committed to inclusion, Kate has spent nearly a decade spearheading meaningful conversations about the significance of diversity, equity, and inclusion in corporate strategy. She believes the foundation of cultural change begins with expanding the definition of diversity, then drawing a direct correlation between employee personal experience and business performance. Kate advises decision makers on how to not only envision, but also become change within the organization to maximize meaningful outcomes. The result is high-performing teams and increased engagement, a better human experience for employers and customers alike. Kate oversees and facilitates the strategic DEI program for multiple financial institutions across the Midwest in her role as Assistant Vice President, Diversity Officer for QCR Holdings, Inc. In addition to introducing and implementing strategies, she cultivates valued relationships with an expansive network of resources that reflect her broad representation of diversity. Kate holds her Certified Diversity Professional designation from the Institute for Diversity Certification. Please welcome Kate.
Good morning, Myra. Thank you so much for such a lovely introduction. I have to say that, I almost wish I wouldn't have watched that lovely CSC Los Angeles video right before my presentation here today, because I was like you, I was kind of holding back the emotion and so touched by all of the amazing depictions of people and the community and the amazing things that CSC does. So I'm thrilled to be here. I have had the amazing opportunity of developing a relationship with CSC, and I've had such a privilege to get to know Julia Forth. Very thankful. Just wanted to say thank you to you, Julie, as well as Elizabeth and Kelly for all of the help and resources with being connected here today. So CSC, what an amazing organization. So I don't have to tell everyone here, but we know the CSC is the largest professionally led nonprofit network of cancer support worldwide, right? And CSC gives more than $50 million of free support to patients and families annually. And it all started right here in Los Angeles. What an incredible accomplishment. And I think on top of just the magnitude of what CSC does, the footprint and the outreach, I think one of the things that we're going to talk about today is the professionalism and the call to the highest level of professional accountability for everyone who's attending the Mental Health Equity Summit today. So a couple things. You know, it's a difficult time for so many reasons. And I think the Los Angeles market, right, is very complex because we have a number of different locations there. The communities are incredibly diverse, right? And not just the way that people look, not just the kinds of diversity that people can see, but wow, people from all walks of life, different cultural backgrounds, different stories, different lives. And it's a huge area on top of that. So I think the challenges here for health equity, specifically in the Los Angeles market for CSC, has some unique challenges. And so I'm gonna sort of walk us through, you know, a couple of things that I really want us to think about. And after talking with Julia and really understanding some of the unique dynamics in Los Angeles, I have sort of a few calls to action that we'll talk about along the way. So first and foremost, it's a complex world that we all live in, and I said that a second ago. No matter who we are or where we live in our country, no matter what news station we sort of tune into, right? Whether we are folks that get up and watch CNN in the morning, or if we tune into Fox News, MSNBC, CNBC, it really doesn't matter what we watch, what perspective of the world we choose to tune into. The bottom line is, for all of us in this country, is that every single day, right? Every day there is a major headline story having to do with diversity, equity, and inclusion. And again, depending on what you're tuning into, you're going to get different perspectives. Oftentimes, those perspectives are based in a number of things. Beliefs, values, goes as far as, you know, political affiliations, religious practices and beliefs, education. There's so many things that go into the different sort of narratives that we're shown on a frequent daily basis. And something unique and remarkable about CSC is that there's a distinguishing of the level of professionalism that CSC and all of its members, affiliates, healthcare providers, there's a level of professionalism that is part of the CSC brand. It's part of the reputation. It's part of what really makes CSC great, right? It's not just the largest network of cancer support worldwide, but it is the largest professionally led network of cancer support worldwide. And so I think that the expectations are different. I think that the call to action is different. I think that accountability is different for everyone who's tuning in today. So we go back to, right, no matter what news station we watch, no matter what kind of social media platforms we like to tune into, every single day we see some major headline about diversity, equity, and inclusion, about our country's culture, and it's very confusing. And one of the things that is common is, it's politicians, CEOs, business leaders, doctors, attorneys, coaches, athletes, artists, musicians, it skips no one, right? Even right down to ministers and priests and, all kinds of folks are sort of getting called out about, right? Something having to do with diversity, equity, inclusion. Something that was said, something that was done, comments that were made, items that were posted, emails or things that were written that have caused concern. And all of these professional folks are having to stand up and explain the situation at hand and getting really called onto the main stage of diversity, equity, inclusion in our country. And this is a challenge, right? Because oftentimes these different information resources present diversity, equity, inclusion in a way that's divisive, in a way that's polarizing. And as professional leaders, look, we're called to a higher level of accountability. We're called to a higher level of professionalism. And people expect us to be who we say we are. So specifically for CSC and the focus on closing the gap in health equity, right? Paying attention to the disparities that exist within the quality of cancer support, who receives that support, how we're able to be intentional, how we're able to provide accessibility to everyone. And to get that message out, I think that's a big task. It's not something that's going to be done easily. It's not something that will have a linear approach to the best path forward. It's something that's going to require, like I said, the highest level of professionalism, accountability, but also innovation and creativity. And one of the things that I want to do is recommend to everyone on the call today is to be innovative and to expand how we see diversity, equity, and inclusion, because that will make all the difference in the quality of care regarding mental health that we're able to provide our communities. So I'm going to start with sharing a little bit about myself. As Myra said, my name is Kate Hightshoe. I was born in the 70s in South Korea, and I was abandoned at birth, so I'm adopted. And my parents are white, my family's white, and because there's such a huge focus on race, there are probably some of you who are thinking right now that this whole conversation is really going to be focused on race. And people are sort of fatigued about the divisiveness and the polarizing conversation around things like race, gender, sexual orientation, and that whole DEI sphere right now in our country. And again, our news and media aren't helping situations whatsoever. But before I get too far along during our time, I just want to say, this isn't going to be a conversation just about race. This is not going to be a conversation that sort of paints an us versus them scenario. This is about diversity of all kinds. This is about inclusion first, And again, really focusing on CSC and the idea of health equity and what that means for cancer care, especially over the next years, right? Because I think the needs are greater than what they've ever been before. So yeah, I was born in South Korea in the 70s. I was adopted by my amazing parents. They were what I like to call diversity, equity, and inclusion trailblazers of sorts. They adopted me during a time when it wasn't necessarily the thing to do. This is before the Brad Pitts and Angelina Jolies of the world made it really popular for kind of wealthy white folks to adopt little brown children from all over the world. And I went to an all-white school. This is before the days of multicultural festivals and Black History Month and Women's Appreciation and all of that kind of thing. So my perspective is in many ways one of experience. And I've found over my lifetime that when people think of diversity, they go straight to race and gender first, followed by sexual orientation, followed by people of different abilities, sometimes veteran status, sometimes second chance citizens or people with criminal backgrounds. These are sort of the historical demographic categories that we have created within the space and conversation of diversity. And as people who are involved in health equity, especially in Los Angeles, there's been no better time than for us to redraw the lines of diversity. Look, you know, if we look up the definition of the word diversity, it simply says variety. It says how we're different. It doesn't say whether those are good differences or bad differences. It just talks about diversity as a variety, how we're different. But when we have a narrow definition of diversity, we miss out on incredible opportunities to be our best selves. We miss out on opportunities to build meaningful relationships. We miss out on opportunities to have the most impact that we possibly can as professionals. And I know that a majority of folks on the call today are high-level professionals with tons of experience, oftentimes probably with a lot of educational background and knowledge and expertise. And because of that, right, it's not just CSC saying that they're focused on closing the gap in health disparity or disparities within health equity, but it's also each individual's character and the professional accountability that we have to truly be our best selves. And I think oftentimes we do a really good job at compartmentalizing, right? So we're able to know all of the right things to say and do, but what is the authentic message that's being sent to our clients, our communities, our patients, their families, and each other, right? Because if we're not doing really the hard work, which I call the heart work, if we're not focused on hearts and minds, at the same time that we're focused on cancer care and programming and strategic plans and goal setting and key performance indicators and metrics and data, if we're not focusing on the hard work, which is the heart work, we have a major gap. And people will know that what we say and then what we actually do aren't in alignment. And that becomes a problem. That makes our programming less impactful. That makes our, any kind of our community outreach less meaningful. People will have a sense that we are less authentic and our character gets called into question. And that's challenging. That's challenging in today's world because there's the highest expectation we've ever seen for leaders to be who they say they are. People are expecting our values, our beliefs, our mission statements, our vision, all of those kinds of things. If we say we are something, people expect us to be so. So when we think of character from a professional standpoint, the definition of character is the gap between what we say and what we do. And oftentimes I think that as business leaders, as healthcare providers, as service providers, it's very easy for us to start to sort of take a one sort of approach to all people, right? So we know what we need to do. We know what all of the facts say about different communities. We know that we need to be inclusive, but we have these barriers in place that we need to work on. And again, I think that for professionals, high-level professionals, leaders in such an important space, not just in the state of California, not just for Los Angeles, but around the world, we absolutely have the highest level of responsibility to do and be our best selves. So what does all of that mean? Well, first of all, we need to challenge how we see diversity. We need to be able to expand our diversity definition. We've got to be more inclusive with who gets to be counted as diverse. Okay, and there are so many reasons for this. When we have a narrow definition of what diversity is supposed to look like or who fits into the diversity definition and paradigm, we are going to make some incredible missteps, right? We're going to miss out on opportunities. We are going to miss out on partnerships, relationships. When it comes to philanthropy, when it comes to partnerships, we make assumptions based on who we think is diverse. And today's buzzword that we use for these assumptions is bias. But the more we expand how we see diversity, the more we expand who gets to be diverse and what that looks like, the more opportunity we're going to create, not just for CSC, not just for, right, the Los Angeles communities, but for every person that we come in contact with. So first and foremost, at the highest level of professionalism, which requires commitment and accountability, it requires character. It requires for us to be who we say we are. The first step is expanding our diversity definition. So, I want to share just a couple of stories about what this really means. Oftentimes we make assumptions about people based on what we see. And again, when we do that, when we have a narrow definition of who's diverse just based on visible diversity, not only are we not being our best selves, not only are we not performing at the highest level of professionalism that we can, but we are not practicing inclusion, and we're missing out on valuable moments and touch points and opportunities to build the relationships that truly make us who we are. And, you know, a couple examples here. Funny because I grew up in rural Iowa, again, back in the 70s. And I can remember going places with my parents when I was quite young. And my parents were told they couldn't have any biological children. Of course, after they adopted me, my mom was pregnant. And so I had a little sister who was also white. And we would go places and, you know, people who my parents had known for a long time, but maybe they hadn't talked to, you know, for a while, or maybe didn't know, or just wasn't, you know, wasn't thinking, would run into us and say things like, oh, is that your foreign exchange student? Or they would ask me if, you know, I was babysitting for my own little sister, if I was the babysitter or the nanny. And that was really difficult because people were asking those questions just based on appearance, right? Just based on the fact that they could tell I looked different than my sister. And it damages comments like that, making assumptions based on only the things we can see. You know, they're hurtful, but they eliminate incredible opportunities to build connections with people. And part of what this whole DEI conversation about is inclusion. It's making sure that every person, no matter who you are, no matter what background you come from, no matter how you put on your pants in the morning, no matter how you put on your shoes, no matter what your educational background is or what your socioeconomic background is, that you are included and that you feel a sense of inclusion. And the way I like to think of inclusion is through 3 key traits. Inclusion has to do with welcoming, belonging, and the existence of a safe space. And the only way to create that for all people is to make sure that we have a very open idea about what diversity is and what it looks like. I don't think there's been any moment, at least in my lifetime, where these things matter more than they matter right now. And it's incredible because as healthcare providers, as people in the cancer care space, especially in Los Angeles, which is such a significant market for, oh my gosh, the American dream. You know, it is such an important place in American history, to our collective memory as Americans. There is such a great need to expand who gets included, who has access to care, and the perceptions that really are embedded in how we see people. I think that, you know, bias comes into play here. as professionals, again, we have an accountability to sort of check ourselves and ask ourselves the tough questions. We have to be willing to look inward. We have to be willing to be honest about our own perceptions of people of all kinds, different backgrounds. And that's sometimes challenging. So the first thing, right? And we've sort of gone over some of those key actions and takeaways already, but the first thing, right, is expand your diversity definition. Diversity is far more than just things we can see. It's more than race and gender. It has to do with our beliefs, our values, our family background, familial and marital status, socioeconomic upbringing, educational backgrounds, everything from those types of personal experiences and characteristics all the way into, whether or not we like sports, what kind of food we eat, where we like to hang out, what we like to do with our spare time. All of these things have to do with diversity, because again, diversity is simply our differences. And when we have a narrow definition of who's diverse, we don't see people we should see. We have blind spots. And we're not being truly inclusive when we have a narrow definition of who gets to be diverse. The important thing to remember here, though, is that inclusion is where the magic happens. If diversity is just our differences, inclusion is where we are able to acknowledge, recognize, celebrate, uplift, value, respect differences of all kinds. Differences of all kinds to involve all different types of health and wellness, from physical health and wellness to mental health and wellness. Inclusion is when we're able to uplift, celebrate, I'll say it again, uplift, celebrate, respect, value, acknowledge, observe, all of those differences that make us unique. But unfortunately, what a lot of people do is they stop with just the differences. They focus on how we're different. And that continues to divide us. That continues to be polarizing. So instead of stopping with just how we're different, we want to find common ground, similarities, have empathy, find out where we have intersectionality. And it's from those places of common ground that we build a strong foundation. Okay, so again, diversity, how we're different. Expand how you see diversity, right? More than race, more than gender, to include everyone, because that's actually authentic inclusion. Remember, when we have a narrow definition of diversity, we miss out on incredible opportunity to build powerful, meaningful, foundational, trust-based relationships. And while differences are amazing, the magic happens in inclusion, because that's where we actually celebrate how we're different. But we don't stop there. We move forward into also finding similarities, common ground, intersectionality, from which to build a strong foundation. And on top of all that, when we're really, truly living diversity, equity, inclusion, according to the values, according to the vision of CSC, we're thinking about accessibility. We're thinking about accessibility, and we are not only just thinking about access and accessibility, but we're thinking about how we remove barriers. And not just removing barriers for some, but for as many as possible. And one of the things I like to say is, leave no one behind. because our communities are only as strong as our weakest link. So leave no one behind. And that statement has truth, no matter whether you're talking about your own CSC teams of employees, of staff, whether it's your affiliates and partners and healthcare providers, whether it's people that volunteer time to CSC, and whether it's your community that you work in, the hospitals, the facilities, the organizations, or the patients, clients, and overall community. All of these factors are critical when it comes to the commitment that CSC makes with the identity and the character that CSC stands behind and believes in. And again, you know, it's very clear, right, that CSC is not just the largest cancer care nonprofit worldwide, but it's professionally led. And I think that's incredibly important to not only value, but to remember and to make sure that every day we're challenging ourselves to be just a little bit better. Just a little bit better, right? Because we know the sustainable and meaningful change is incremental. It's the little bits every day that over time make us a whole lot better. So this is a really unique platform for me. I'm used to sort of being someone that feeds off of the energy in the room, the connectivity between people, seeing people's beautiful faces. And so a webinar style format when it comes to diversity, equity, inclusion, it's been a wonderful, beautiful challenge for me professionally to find out how I sort of create that same spark and feeling for all of you today, even though I can't see you and I'm not sitting in the same room and I can't feel the energy from all of you. But if there's one thing that I leave everyone with today, it's we can all make a difference. You know, over the last however many years, we've seen so much divisiveness, so much turmoil and angst and trauma. Everything from, right, some of the most highly divisive political, you know, elections, and we're on the brink of another one. I'm terrified, right? We have, right, the Me Too movement and Black Lives Matter movement and COVID. Nothing's more divisive than COVID, right? Vax, no vax, mask, no mask. We have people who think it doesn't exist, people who think it's never going away. And then after that, we had, oh my goodness, and we've got, right, Roe v. Wade, we've got increased hate crimes against Asian Americans, we've got all of these huge factors happening in the world around us. On top of, right, all of the different messages that are being sent to us through different types of communication channels. Can read all of the comments on Facebook. You know, you can see all the different social media stuff, different news stations, all of this information about what diversity, equity, inclusion is and what it means. And it tells us a whole lot all the time about, you know, white people and Black people and old people and young people and males and females and all of these different sort of siloed buckets that we have tried to put each other in. And so every single one of you today can make a huge difference in not only the perception and the work of diversity, equity, inclusion, but continue to live the values and the mission and the vision of CSC. So I invite everyone, right, to think about expanding your diversity definition, truly practicing inclusion, creating a welcoming, belonging, and safe space for all people, and having self-awareness and the desire to be just a little bit better, right? Because we know that a little bit better every day equals a whole lot better over time. So Cancer Support Community Los Angeles, thank you so much for your time today. Such an honor and privilege. You know, I have really enjoyed being here. Very grateful for Julia and the opportunity to spend a little time with you today. And if there are any questions, feel free to reach out to Julia. And, you know, I'm happy to try to find a way to connect in the future. So thank you so much. Thanks, Myra.
Thank you so much, Kate. And thank you for inviting everyone to be innovative, you know, to expand our definition of diversity. And for also reminding us that, you know, what we say and do must be in alignment, right? And I love that you said that inclusion is where the magic happens, you know, saying that that's where we uplift, we celebrate, we respect, we value those differences and the differences of all kinds, right? And, you know, I really, I'm going to put into practice what you were saying about, you know, we can celebrate our differences, but not stop there, right? To also move forward to finding that common ground to that, so that we can build that strong foundation. So thank you, you know, for giving us that talk about the importance of inclusion, you know, diversity, equity, and how, you know, that's how we make a difference and taking that on. So we really appreciate you, Kate. So thank you. And like Kate said, everyone, if you have any questions, please feel free to email us and we'll get them to Kate. Welcome back, everyone. And now I'd like to present our next speaker. Lisl Schweers is the lead psychosocial clinician for the Life Cancer Survivorship and Transition Service in the Cancer and Blood Disease Institute at Children's Hospital, Los Angeles. Her clinical interests include the incorporation of mindfulness-based practices into the psychosocial care of cancer survivors, healthcare transitions, and teaching advocacy skills to patients and families. Ms. Schweers recently served as the Legal and Advocacy Chair of the Association of Pediatric Oncology Social Workers. She is on the Professional Advisory Board for the Cancer Support Community Los Angeles and is a member of the Society for Social Work Leadership in Healthcare and the Association of Oncology Social Workers. Please welcome Lisl.
All right. Thank you again to all the folks, all the great folks at Cancer Support Community Los Angeles for inviting me to speak to you today about, you know, sort of the nuts and bolts of pediatric and adolescent survivorship, transition, and advocacy. I am a 23-year veteran here at Children's Hospital Los Angeles, and I've been working in our Children's Blood Disease Institute for about 15 years now, almost 15 years. And what I'm going to talk to you about today is obviously through a psychosocial lens. I'm a clinical social worker. And as Myra mentioned, I'm the clinical social worker, the primary psychosocial clinician for our survivorship or long-term follow-up clinic here at Children's Hospital. So I'm going to provide a brief overview of some of the medical issues that our survivors face. But really, I'm going to focus on some of the psychosocial late effects. I'm going to talk about the transition planning and transfer of care and how we teach advocacy and how we encourage advocacy on multiple levels for our constituents. So again, I'm going to go briefly over the physical and emotional late effects of cancer. This is what we do every day. I'm going to talk about some of the advocacy priorities that are relevant to the pediatric and AYA cancer community, but there's also some correlation with adult oncology too, and some of the legislative issues that I'm going to talk about towards the end. And then I'm also going to talk to you a little bit about how we prepare our kids and our teens and our young adults to be good self-advocates to optimize their quality of life over the long term. Just to give you a little bit of perspective and context, this is Children's Hospital Los Angeles. We're in East Hollywood. For those of you who are in the LA area, you'll probably know where that is. We serve a very diverse population. We serve about 70 to 75% of patients who are insured by Medi-Cal, which is the state Medicaid program in California. We serve a large Hispanic and monolingual Spanish-speaking community, as well as many other ethnicities and diverse populations throughout Southern California. We also have a global reach. We have a global health center, so we treat children from just about all over the world, including surrounding states. So what I'm going to talk to you about a little bit is really the nuts and bolts, like I said, the nitty-gritty, the practical approaches that we use to take care of kids and adolescents who have had cancer. We do have an outpatient clinic. That's primarily how we practice. We have clinic 4 days a week, and we see about 1,500 patients per year. We serve all oncology patients and patients who were treated with bone marrow transplant, CAR-T therapies. We take children who are also, perhaps they were treated at another facility and they moved to Los Angeles. We take patients from other institutions. We do a lot of work around transition planning and help our young patients transfer their care to adult medical homes about the age of 21. I'll talk more about that in just a little bit. Our core team consists of a nurse practitioner, pediatric nurse practitioner, pediatric oncologist, and new to our team is an occupational therapist. We see new survivors 1 day a week. Those are children who are referred to our program for the primary disease team when they're about 2 to 3 years off treatment. Some teams refer a little bit earlier. Some teams refer a little bit later. They want to hang on to those patients just to really try to make sure that all the on-treatment medical concerns are well managed and under control before they refer to the survivorship program. However, I will say that we are beginning to see survivors a little bit earlier, and we're doing what's called concurrent care. So kids could be still seen by their primary leukemia doctor, and then at about a year and a half, they may be referred to the survivorship program to really start shifting the focus of those visits to really look at coping and adjustment with the new normal, with life after cancer, looking at all the social, emotional, developmental needs of kids as they have experienced a trauma, the family as well, as we know that cancer is a family diagnosis. And so we do a lot of what we call family-centered care here at Children's Hospital Los Angeles, and we do treat not only the child, but the siblings, the parents, the caregivers, everyone who's involved in that child's life. These are the brochures that really, describe what we do and how we do it. These are both available on the Children's Hospital Los Angeles website. The flyer on the left is a document that describes the referral process and what we do. The young lady on the cover was actually treated at an outside hospital, but she came to the Children's Hospital for many years for treatment for surveillance of her late effects. The flyer on the right describes our transition program. We are Children's Hospital, an affiliate of University of Southern California, and we have a transition program whereby our young adults are usually transferred to USC Norris Comprehensive Cancer Center if they meet a certain criteria and if it's what the patient chooses to do for that survivorship care into adulthood. Again, we see about 30 to 40 patients each week. We do basic psychosocial assessment in addition to the medical evaluation and the teaching of late effects. We also refer for neuropsychology screening for most of our patients, and genetic testing as well, and especially genetic testing for our older adolescents and young adults happens over at USC, where we also refer patients who have concerns related to fertility post-treatment. That's where we send our young adults for evaluation of those concerns. To further set the context, I wanted to just give you a briefly overview of some of the statistics. Many people don't realize that kids get cancer, but cancer remains and is the most common cause of death by disease among children in the US. The most common types of cancer that affect children are different than adults. We see leukemias, brain and central nervous system tumors, and lymphomas are the most types of cancer among children and adolescents. And brain tumors are actually the #1 killer of children who have cancer. 1 in 264 children in the US will receive a cancer diagnosis every year. Globally, a child is diagnosed with cancer every 2 minutes. In addition to the leukemias, the brain tumors, and lymphomas, we also see children who experience solid tumors such as Wilms tumors, which affect the kidneys, osteosarcomas, which is a bone cancer, retinoblastoma, which is an eye cancer. One of the things that makes childhood cancer so unique and the potential to be very deadly is that there's no early detection for childhood cancer. You know, there aren't routine screenings like mammograms or testicular self-exams or colonoscopies like there is in the adult oncology world. So cancer happens out of the blue. We still don't know why children get cancer. That is being researched, obviously, as it is for adults. But, you know, children, the average age for a child to be diagnosed with cancer is age 6, whereas for an adult, the average age is 67, which means that for an adult, maybe there's 15 to 20 years lost to cancer, whereas for children diagnosed at much earlier ages, there's an average of 71 years lost to cancer. And that doesn't mean that that loss is a result of a shortened life expectancy. It's just living with the late effects of cancer treatment for a much, much longer time. In survivorship, we do know that by the age of 50, more than 99%, that's just about every survivor of childhood cancer, will have a chronic health problem, and almost 96 will have a severe or life-threatening condition caused by the toxicity of the treatment that nearly saved their life. Really, another statistic that I think is interesting is generally 2/3 of all cancer patients will have at least one late effect, even a mild late effect, you know, upon completion of treatment. I'm going to go into this a little bit further, but some of the common late effects, the chronic health conditions that we see in childhood cancer survivors are learning disabilities and damage to the brain, neurosensory hearing loss, vision loss. We see a lot of cardiac toxicity and heart disease, cardiomyopathy. We see secondary cancer. Some of the drugs that treat cancer, one type of cancer, may cause another kind of cancer. We see problems with endocrinopathies. We see infertility. We see growth hormone deficiency. And then, of course, functional limitations due to amputation and surgery and other treatments. So this is basically the journey, right? A child is diagnosed, they have a treatment plan developed, they go through maybe the treatment is surgery, maybe it's surgery chemotherapy, maybe it's surgery chemotherapy radiation, maybe there's a bone marrow transplant, and then the treatment ends. And then, like I mentioned, after about 2 years, a child is referred to our survivorship clinic. But all along this pathway, all along this trajectory is transition planning. And when I talk about transition planning, I'm not just talking about transfer of care. Those two terms get conflated a little bit. Transition planning is really about teaching a young person to understand their health history, understand what it's going to take to stay healthy, and really develop confidence in engaging in conversation with healthcare providers and new healthcare providers as they age out of the system and go to new doctors, being able to describe what their diagnosis was, what their treatment was. And we have a survivorship care plan that we review it every year to help that young person, as well as the family, to really understand the history so they can speak competently with providers as they grow up. What's not represented in this graphic, however, is relapse. And we do know that a fair number of children relapse, whereby their cancer recurs and they go back into treatment, or they go to more aggressive types of treatment. We know that, for example, in osteosarcoma, the relapse rate is about 30%. And so those kids may be treated for 1 or 2 years, and then it's another 1 or 2 years. So, we have children that have been in treatment for most of their young lives until they finally reach remission. So when we talk about survivorship, I get asked a lot, and I think many of our providers do as well, when do I call myself a survivor? And that is a very individual decision, and it's a label that we believe that people have to feel and want to identify with if they choose to. Some people at diagnosis may consider themselves survivors. Others might wait until they've completed treatment, or maybe 5 years treatment. So really, we encourage folks to consider that label or that identity is just part of the puzzle, right? We are very complex creatures, and we are daughters and sisters and students and Californians and Geminis, and we have all these labels that we ascribe to ourselves depending on what role or what activity we're involved in. And so I like to coach patients to kind of think of it that way, and to maybe think that today, when they come in for their annual late effects visit, that their survivorship or their survivor identity is pretty big. But hopefully, once they have their evaluation and get their education and go to lab and then sort of go on their way, either back to school or back to work or back to play, that the survival identity or their survival label doesn't go away, but maybe it shrinks a little bit and goes back on the self, so they can, really nurture and develop other parts of their identity that are very meaningful to them. So in talking about survivorship too, we want to look at what is survived. And these are some of the things that we address in the annual visits in the Life Clinic at Children's Hospital. We know that obviously the illness itself and the trauma associated with painful, scary procedures that are part of cancer treatment, the immediate side effects, the nausea, the hair loss, the fatigue, the pain, and then the late effects. So those are definitely survived. Then we think about vicarious trauma and children and families making connections, making friends, and seeing the trauma that's being inflicted on patients that they've become close to. We think about, siblings and other close friends and family members who are not experiencing the threat of life themselves, but are exposed to the trauma of having a loved one potentially facing a life-threatening condition can be incredibly traumatic. The grief and loss associated with the loss of that idealized childhood, a loss of a potential future as someone who may be unable to bear natural children. There are losses associated with sensory loss, vision and hearing, as well as functional limitations, maybe related to an amputation for a bone cancer survivor. We know too well that the strain on family and interpersonal relationships can be very, very profound, as cancer disrupts all major life activities to one degree or another. The financial toxicity that we hear about so often now is real. Many times the financial problems, especially for the childhood cancer community, is related to a situation where maybe two parents were working and one parent needs to reduce their hours or stop working altogether to be able to attend to the child when they come to the hospital and manage all the care at home that's also needed. We don't have perfect leave laws in this country just yet, but the stress related to taking time off from work missing wages because of time taken off for work can really lead to the financial strain. And then, of course, for children, the educational and social disruptions. The activities of childhood are school and play for the most part. And so when there have been developmental gains achieved and cancer comes into the picture, and some of those activities that instill competence and mastery are put on pause, you have, situations where kids really can be challenged in maintaining friendship and relationships with peers. There are things that are missed out on: school, field trips, first dances, family vacation. So again, the survival is not just, surviving to live, but, surviving a lot of the psychosocial impacts of cancer is something that we take is very, very important. And the ripple effect that cancer can cause is something we really want to pay attention to. The psychological late effects, I know some of our other presenters spoke about the anxiety, depression, the post-traumatic stress. These symptoms are also very prevalent in child and adolescent cancer. These are issues that we screen at every single visit, which is part of our psychosocial evaluation. We use screeners such as the PHQ-9, the GAD-7. We also screen for thoughts of self-harm and suicidality. And of course, with the pandemic over the last few years, someone who was already at risk or vulnerable for some of these psychological side effects and late effects of cancer treatment, those concerns have only been compounded with the isolation and the stress caused by the COVID pandemic. So unfortunately, we're seeing a lot of kids really struggling to get their grip as far as their, not their grip, but their footing to kind of get back into that normal routine. These are some of the concerns that survivors express to us. There's the fear of recurrence. There's that always, when is the other shoe going to drop, right? Every lab test, it's a waiting game. It's a holding of a breath to, anticipate whether or not the child will recur. And then there's something called survivor's guilt. There's a lot of relationships that develop. Families meet other families, kids meet other kids who were in treatment, and not every child survived. So, the guilt associated with, well, my child lived, but yet our neighbor child did not survive. And so there's guilt associated with that. There's the grief associated with the loss. And as I mentioned, the loss of that normal life. There are cognitive changes due to some of the treatments that affect learning, interpersonal relationships. And as I mentioned, the fertility problems are fairly significant in many of the patients that we see. There are anxieties around body image, self-esteem, disclosure. There are children who were treated when they're very young, and so they may be in a new middle school and have made new friends that have no idea that they're a childhood cancer survivor. And so, we talk a lot about disclosure, about when to tell, do we tell, who do we tell, how much do we tell? And this is, again, also particularly poignant for young people who are engaging in relationships and dating relationships and marital relations, and talking about whether or not there's a fertility issue. These are things that young cancer survivors have to negotiate, which their peers typically don't. And then, of course, the financial toxicity, the access to healthcare, access to the right kind of healthcare, insurance, the medical debt. Those are problems that persist well into survivorship that are definitely stressful and can cause distress for many families. However, as we learned yesterday, I loved Bill's quote, turning grief into glory. So on the flip side of post-traumatic stress, we see a lot of post-traumatic growth. We see new opportunities and possibilities that are established. We see kids who had an amazing doctor or nurse or physical therapist who now wants to, be a healthcare worker in the future. They see the possibilities. We see some definite positive changes in relationships as well. Families can be challenged, relationships can be strained, but they can also be brought closer together. Learned resilience, we see that quite frequently. Children reflect back and families reflect back on their journey, their struggle, what they've overcome, and develop a new sense of confidence. There's a greater appreciation for life. We see a lot of young people who are wise beyond their years. They understand, the risk that they carry and how they have overcome, and have maybe a greater appreciation for life and see opportunities to seize the day. And then, of course, folks' faiths are challenged in incredible ways. And we also see, a strengthening in one's belief system for folks that have survived cancer. So again, some of those are the things that sometimes are pretty evident and folks can identify. Sometimes we have to help them get to this place or help them explore what some of the positive outcomes are, especially if they're sort of dwelling in some of the negativity that's holding them back. We like to, sort of bring that out a little bit at every visit if we can, and generally it comes quite naturally. So to deal with some of the distress that we see, at every visit, we really, really evaluate the care that someone is getting on an emotional level. We talk about the grief response. We teach strategies to reduce anxiety, some of the irrational thoughts. Some of that is just getting clarification about risk and about percentages and about chances of recurrence. Some of that's psychoeducation. We definitely encourage families and children to engage in psychotherapy if that's something that we think would strongly benefit them, and again, refer to support groups and social support. We have many teens who want to come back to Children's Hospital. They want to give back. They want to volunteer. They maybe want to talk to another kid who's going through it because they feel like they can share their story and make a positive impact. We talk about the importance of sleep hygiene, good nutrition, exercise. As kids get older, their risk of developing health problems related to their treatment plateaus to some degree. And then some of the just sort of natural wellness activities are neglected. And so we really, really reinforce, good self-care. And then obviously, staying educated is really important. Asking questions, providing information about blogs and survivorship resources that are available online, attending seminars and workshops such as this. Some of the referrals we make are to camp. There's the Children's Oncology Camping Association, which provides certification for oncology camps all over the country. We refer to programs such as Coach Art, Team Impact, Pavlov Shutterbugs, First Ascent. These are all programs designed to teach new skills, form community. Even though the child might sign up for Pavlov to do a photography class, what they're doing is they're also meeting other kids who've had a similar experience. So there's a real support mechanism in place for all these arts and sports and adventure programs. And then, of course, the cancer support organizations such as Cancer Support Community. Elephants and Tea is a wonderful AYA resource that has digital support groups listed on their website. Programs such as Pediatric Brain Tumor Foundation, the Leukemia Lymphoma Society, and MIB Agents, which is an organization dedicated to the support of patients with osteosarcoma. So again, really helping families remember that these organizations and these programs are available for survivors as well as folks going through treatment. briefly, I wanted to go over some of the late effects. This guy on the screen is called Chemo Man, although I think we should be a little more inclusive and call him Chemo Person. But just to give you an idea, there are drugs such as cisplatin and carboplatin, which cause problems with the kidneys and hearing loss. There's a drug called bleomycin that can cause pulmonary fibrosis. There are drugs that cause infertility, such as cyclophosphamide. We know that methotrexate is given for most of our leukemia patients intrathecally, and that can absolutely affect neurocognitive development. The steroids that are used can cause cataracts and joint problems. So some of these effects of chemotherapy are present right away, especially something like a drug called vincristine, which we know causes peripheral neuropathy. But many of the chemotherapy treatments, as well as the radiation, we won't see the late effects of those treatments until many years later. That's why the annual surveillance and the screening is so important. Survivorshipguidelines.org is a website that the Children's Oncology Group has developed, and the long-term follow-up guidelines are reviewed and updated every few years. So what clinicians and patients and families can do, they can actually go to that site, they can download the guidelines, they can look up the drug that they received and understand what the potential risks are, but more importantly, what are the surveillance and screening recommendations for that particular drug. So that's pretty much what our nurse practitioners do. They review the treatment history, calculate and write down all the cumulative doses for all the chemos and the radiations, list surgical sites, and then develop sort of an algorithm or a flow chart of what screening tests and recommendations are indicated at particular time points. So again, just to recap, this is what we do in the Life Clinic. You know, we do the risk-based screening to hopefully identify any potential late effects early on. So intervention can occur sooner rather than later. We educate. So we educate parents, we educate kids as they grow up. You know, every time I go into a room, depending on the age of the child, I'll ask them why they're here. Do they know, what type of cancer they have? What are they doing to take care of their bodies? Health promotion is really, really big, that anticipatory guidance, not only about later cancer screenings that we know, for example, a young lady who receives, mantle or chest radiation, we're going to start mammograms at a much earlier time than their peers. But we also talk about safer sex and getting immunizations current, and talking about the importance of exercise as medicine. Sleep hygiene is huge. So we provide some tools to help them gauge their progress and to keep track of things. We also encourage a connection with the PCP. Many times children going through treatment won't see their pediatrician throughout their cancer journey. So we really encourage follow-up with the PCP to get caught up. We refer to the subspecialists for children that have problems such as the cardiac toxicity or kidney problems, endocrinopathies, and then we work on transfer to an adult medical home. Transition planning is something that we do at every visit. And this is pretty much across disease populations at Children's Hospital, where we really, we don't wait to the last minute. Transition can start very early. Again, it's about helping kids understand their diagnosis, understand how to take care of themselves, practice, rehearse, asking sensitive and delicate questions. At about age 12 or 13 at Children's Hospital, we generally spend a few minutes alone with each patient to talk about drugs, sex, and rock and roll, and things that they might not be as comfortable or forthcoming in talking about if their caregiver or parent is in the room. So again, transition planning is a forward movement, and teaching self-advocacy is integral in every step along the way. And self-advocacy is really just, again, being able to speak up, knowing who to go to get information, knowing rights and responsibilities. What happens when you turn 18? well, your private health information is then, yours, and you decide who to tell and whether or not you're going to include a parent or a friend in your visit. Learning how to problem solve and knowing who to reach out to, and really, figuring out, what kind of life you want to lead, what kind of decisions you're going to start making on your own. That self-determination is really, really important. And so those are the issues and the concepts that we introduce just about at every visit in different ways, depending on the developmental and age of the child. Self-advocacy is also important for parents, right? It's really, really hard for parents of a child with cancer to realize that they're not always going to be in the exam room, or they're not always going to be in control of the decision making and involved in every conversation. We encourage young people to have a support system involved in, especially in important medical decision making. But again, that authority or that privilege shifts to the patient when our kids turn 18, and we do a lot of counseling around advanced directives and such. So again, just to show you our transition pathway for the lower risk patients, standard risk ALL, low stage Wilms tumor, maybe a surgery only solid tumor at age around 21, we refer to the primary care provider for follow-up, and then we have a nurse care manager in the life clinic that reaches out and calls that patient once a year just to see how they're doing, see if they have any barriers to receiving care from their primary care physician. For our higher risk patient, that's anyone that received radiation, transplant, high doses of anthracyclines, which we know can cause cardiac toxicity. We hope to see at our program at USC, or if they live in another part of the city, we might refer to City of Hope, UCLA. Those are the two other programs that we typically refer to. Some of the tools that we use for transition, again, the survivorship guidelines on the COG website. We provide a survivorship care plan. Every survivor, whether you're an adult or a child, should have a survivorship care plan with outlining the plan for surveillance at the end of treatment. The transition readiness assessment is a great tool to use with young people to gauge their readiness. Do they know the name of their medication? Do they know how to make an appointment? Do they keep a copy of their insurance card in their wallet? Do they know who to call if they have a question about a particular issue? We definitely encourage activation of patient portals for ease of access to medical records, and then GOT Transition is a great sort of a universal guidelines for transition to support transitions for all populations. We do a lot of education around education and vocational rights and legal issues. We support patients in accessing special education and Section 504 of the Rehab Act, which allows for accommodations at school and the workplace. We encourage linkages for patients that need it for Office of Students with Disabilities. And again, we also review all the scholarships that are available for young adults who have survived cancer. Many, many wonderful programs out there. We typically refer folks who are receiving SSI or supplemental security income to the Department of Rehab for occasional and vocational training assistance. We have some patients who have been diagnosed with another condition. Maybe they're on the autism spectrum or have Down syndrome, or they have a significant neurocognitive deficit, which impairs their ability to live independently, and they might need conservatorship. So we refer to the regional center for support with those, with case management and long-term planning. And then, of course, some of the other legal issues relate to long-term planning. You know, living wills and advanced directives are for everyone, not just for cancer patients and survivors, but this is something that we review on a fairly regular basis, again, to help that young person understand their right to self-determination and to make those decisions if they become unable to make those decisions. Conservatorship, special needs trust are things we talk about. And again, reviewing insurance laws and medical leave laws and what other benefit programs might be available. So when talking about equity, we also have to consider that there are barriers. Only about 20% of childhood cancer survivors are actually being seen in a long-term follow-up clinic, that doesn't mean that they're not getting care necessarily, but it may not be the specialized their care. We do lose patients who just, want to avoid, want to deny, want to just go on with life and never think about cancer again. We have patients that really just don't quite understand how significant their risk is, so there's a knowledge deficit. We have plenty of stories of patients who have inadequate health insurance coverage that will not necessarily guarantee their referral to an NCI Center of Excellence for their cancer surveillance, or they might not be able to get the scan that they need. Again, that's typically due to maybe the primary care provider or someone at the insurance company not really understanding the long-term effects and the research that shows that this care is needed. We see lingering financial toxicity and, of course, social determinants of health. The social determinants are the environments in which we live, which determine our ability to have self-determination, to access education, healthcare, even food, the hierarchy of needs. And those social determinants can definitely impact whether or not someone has the ability to engage in survivorship care. So the social determinants and some of these other things, again, those are things we screen for at every survivorship visit. On the flip side, there are some things that we can do to make things a little bit easier for childhood cancer survivors. So I'm going to go into some of the legislative issues that I think they're important for all of us to be aware of. Most notably, the Affordable Care Act, which I know everyone is probably very aware of. It was signed into law back in 2010. It's definitely not a perfect law, but there are things that, irregardless of which side of the aisle you're on, folks can agree on, things like pre-existing conditions. Before the ACA, a young adult living with cancer who's perfectly healthy but may have some risk factors, they couldn't afford insurance because their premium was so high just because they had cancer. Well, that's illegal now, that kind of discrimination. Also, young adults, until they get their footing, if their parents have employer-sponsored health insurance, they can stay on their insurance now until the age of 26. Medicaid expansion has been huge, and we think that through the literature that that's one of the biggest benefits for childhood cancer survivors, and that's how more folks are covered, not necessarily due to the pre-existing condition or young people staying on their parents' insurance, but the states that expanded Medicaid, we know that there's been an increased access to care. And of course, the routine cancer screenings at no cost, which people of all ages can benefit from. There's another act called the Accelerating Kids Access to Care Act, which just got a couple new sponsors this week. It's a bill that I'm tracking. This will allow children to have more timely diagnosis and treatment if they live in an area where there's not a pediatric cancer program. This law will allow states to have reciprocity, actually the providers who accept Medicaid or Medi-Cal to have reciprocity. So for example, a child in Phoenix, Arizona might need to come to Children's Hospital Los Angeles, but their insurance is Medicaid. Well, their provider that they may potentially see in California would need to be paneled with Arizona Medicaid. So this law would actually break down those silos and those barriers and have more interstate movement of patients getting care quicker. These are a couple of laws that were really, really helpful for young adult survivors. The deferment for active cancer treatment allowed borrowers to defer their student loans during treatment and 6 months after, so they could take a little bit of a pause and not be accumulating interest while they're going through cancer treatment. And then fertility preservation. Many health plans do not cover fertility treatment, and many do not cover fertility preservation, but this law clarifies that for anyone undergoing cancer treatment, healthcare plans in the state of California must include coverage for standard fertility preservation. That includes egg harvesting and storage, semen banking, ovarian tissue harvesting and storage for prepubertal girls. Note that this fertility preservation law does not impact Medicaid, though, so there's still a large population of children going through treatment who have Medicaid who have no access to fertility preservation because the cost is prohibitive. The California Cancer Care Equity Act is something that I know many adult oncology programs are also getting behind. This act was actually passed very recently in August, and it's sitting on Governor Newsom's desk. And I encourage everyone, if you're interested to learning more about the law, to just Google, California Cancer Care Equity Act, and there's an opportunity for you to write to the governor. What this law will do would ensure that Medi-Cal recipients in the state of California can access the clinical expertise and resources at NCI designated cancer centers. Many times Medi-Cal recipients are treated at community hospitals or by community providers that don't necessarily have access to clinical trials and novel therapies. And so treatments are maybe not as aggressive or cutting edge as someone who's treated at a NCI designated hospital. So this law would help Medi-Cal patients have access to higher quality cancer care in the state of California, and we hope the governor signs that. The PCHETA, the Palliative Care Hospice Education and Training Act, is really important for the pediatric cancer community. The AAP actually recommends that palliative care be offered and discussed even at diagnosis, and a lot of people are reluctant to even consider palliative care for children until it is fairly certain that a child is at risk. But again, palliative care and hospice is so important, and this act would actually increase the training, funding, and awareness for pediatric and adult palliative care. The STAR Act was passed a couple of years ago, actually in 2019, signed by President Trump, and this is the biggest childhood cancer legislation ever taken up by Congress. And this was a grassroots effort. Many on-the-ground childhood cancer advocacy organizations, parents, family members wrote the bill, took it to Congress, did lots of lobbying, lots of action days, and now Congress will allot up to $30 million per year for the STAR Act to fund programs that increase research opportunities by expanding biorepositories, expanding cancer registries for children, establishing model systems of care for survivors, and increasing, the pediatric expert at the NIH, which has been lacking for many, many years. Again, it's important to keep the drum beat on. I went to DC a few years ago after the STAR Act was passed and met with Representative Cisneros. He was all on board to, provide the appropriations for the STAR Act, but he was voted out of office. He had a very short term. So again, this is why it's important to keep up the pressure, keep up the lobbying, continue to advocate for the childhood cancer communities, because politicians come and go, but kids and families and the issues very much remain. So it's really important to stay active and on top. And these are some of the things that we can all do for a variety of causes, but really, let your elected official know your story. Tell them you're a constituent and that this matters to you. Ask for the commitment to funding things such as the STAR Act. Write letters for your local newspaper, hold fundraising events, share your message on social media. We know that many politicians are glued to their Twitter. You can use hashtags to really raise awareness for childhood cancer. And most importantly, vote. And I would, suggest, keep health policy in mind when you go to the polls, and ways that we can influence and empower our politicians to make healthcare more affordable and accessible to everyone in the country. these are a couple of the resources that I frequently draw on. The Childhood Cancer Survivor Study is a retrospective study of childhood cancer survivors that were treated in the 70s and 80s, and a lot of the research about late effects comes out through the CCSS, and they publish newsletters. And then the Psychosocial Standards of Care were recently published in Pediatric Blood and Cancer. I think they're 15 standards of care that have everything to do with psychosocial care, education, sibling support, bereavement, palliative care. And those are available for patients, families, cancer centers to evaluate how well their center is doing to address the psychosocial needs of children and families experiencing cancer. And with that, I will stop. Thank you very much.
Thank you so much, Lisl, for that wonderful presentation on childhood cancers and adolescent and young adults. They're often not an included group, right? And so when we're talking about health equity, we can't forget about children and young adults and adolescents as well. Now we have a few questions for you in the chat room. So the first one is, can you speak to the impact of cancer on a sibling and how to help with sibling grief?
Absolutely. I mean, like I mentioned, cancer is a family diagnosis, and especially older siblings, siblings that are old enough to understand, what cancer is. Maybe there's been an experience of an older relative or someone that they know that died of cancer. Cancer strikes fear. So I really think it's important that when we do our assessments of coping and adjustment, that we definitely include siblings and have private conversations with them. Here at children's hospitals and most pediatric cancer centers, we have psychologists, we have child life specialists who do a lot of work with, helping children understand at various ages, kind of dispelling myths and trying to get at what those fears are. Some parents are reluctant to bring the siblings. They don't want to scare them. They don't want to freak them out. But we know that children can be very curious and very bright. And sometimes some of the fears are bigger than what's really necessary. Sometimes the fear is justified, and it's about really, sitting with that young person, having them find their voice and put into words what they're worried about, and providing answers that are age appropriate and that are on their level, and just meeting them where they are. Everybody copes differently. Some people are very stoic. Just, we're going to, get down to business. We're going to get through it. You have parents that become sometimes unavailable physically or unavailable physically. So again, we work with the parents too, to help them understand ways to kind of keep things as normal as possible by including siblings in their emotional care.
Thank you, Lisl. As someone who, has had cancer in her family, I very well understand that cancer involves the entire family, right? That diagnosis involves everybody. Our next question asks, what referrals or services do you offer young school-aged siblings?
Well, it depends on what the issue is. If we're worried about emotional health or behavioral health issues, regression or mood symptoms or acting out in any kind of way, obviously we can refer for psychotherapy, behavioral health. I think, things like I mentioned, the Coach Art program, the camps, those are activities where patients, survivors, and siblings can connect with kids who've been through a similar experience. So maybe they can't go to a regular summer camp. Maybe they can't afford it. Maybe their sibling is still in treatment and immunocompromised and can't do, a regular camping experience or a field trip. So these opportunities are available because most of them are medically supervised or they have medical consultants. And so they're very attuned to meeting the needs of kids and families who've been sick and know what some of the precautions are and some of the psychological needs are. So these, not only do these things teach activities like, piano lessons or karate or cooking, but the providers, the teachers, the coaches, the instructors all have a understanding and knowledge of how to support kids who may not be having their best day and may have other needs that are sort of exposed or brought to the surface in one of those activities.
Wonderful. Thank you so much. We're so grateful that there's those opportunities available for children and their siblings as well. So our next question asks, what advice do you have for survivors to find a PCP who is equipped to understand and support the long-term health issues they may face?
That's a great question. And you know, it's a problem because sometimes we have health plans that will refer a patient for survivorship care to a medical oncologist who may or may not know anything about the needs of childhood cancer survivors. So, you know, I think, you know, asking good questions, you know, of that PCP, you know, do you have any experience with treating childhood cancer survivors? And if not, would you be willing to learn? Would you be willing to go to the COG website? Would you review the survivorship care plan? Would you be willing to talk to my child's oncologist? You know, maybe there's a question, maybe there's a concern, you know, we do that. And some patients, you know, will contact us 5 years, 10 years later. Maybe it's a young woman who's pregnant and she's, you know, she's seeing a high risk OB because of her cardiac precautions, because of her chemotherapy, and maybe that OB might have a question. And so we remain open to consulting to review what those risks are. But again, I think there's an awareness now, and I know at Children's Hospital, because we're a teaching hospital, we do have pediatric residents now that rotate through the survivorship clinic, so they become exposed to and aware of the needs of childhood cancer survivors, and so it's not quite so scary or intimidating. You know, some of these survivorship care plans are 3 or 4 pages, some are 20 pages, right? Depending on the amount of treatment and the toxicity. So it can be a little overwhelming. But the good news is, you know, again, that's why we teach our patients and our families to really, really understand and be good advocates, so they could maybe even help their provider understand what their risks are, or get their provider in touch with us or the experts.
Yeah, I think sometimes we forget that you can interview your providers, right, to see
Absolutely.
who is a good fit for you. And, you know, this next question is actually related to what you were mentioning right now, the survivorship care plan. Someone is asking if you could possibly share the survivorship care plan. They say it can be traumatizing to have to repeatedly dictate history for diagnostic follow-ups and other care, even when it's within the same electronic medical record. And this can be another barrier to survivorship follow-up care. They wanted to thank you.
Yeah. So what we encourage our patients to do, especially our young adults, we say download it, have it on your desktop in a file. So when you go see a new doctor, you can offer to print it or email it, and you can say, read this, you know.
Well, thank you so much, Lisl. We really appreciate you sharing this wonderful information about childhood cancers in adults, adolescents and young adults. Thank you.
Thank you.
Now I'd like to present our next speaker. Dr. Scout is the Executive Director of the National LGBT Cancer Network and the Principal Investigator of the CDC-funded LGBTQ Tobacco-Related Cancer Disparity Network. He spends much of his time providing technical assistance for governmental tobacco and cancer-focusing agencies, expanding their reach and engagement with LGBTQ+ populations. Scout leads a team of specialists who focus on building tools and sharing strategies across state departments of health. He has faculty appointments at both Brown University and Boston University School of Public Health. Scout has a long history in health policy analysis and a particular interest in expanding LGBTQ+ surveillance and research. So please welcome Dr. Scout.
Thank you so much. I appreciate it. Okay, excellent. Then let me kind of start to jump through some of the things I want to talk about today. It's interesting because I feel like some of the issues related to cancer care and equitable cancer care in the queer communities are actually shifting a little bit with some of the different kinds of factors that are going on. So a piece of what I'm going to be talking about is how some of those things are shifting, but what it means and what we're then seeing as far as cutting edge work related to making sure that cancer care is equitable for our populations. I encourage everybody to please put questions in the Q&A box, because without questions, I just get really bored. And so please just, let's avoid that horror show. Throw lots of questions in to make sure the last 15 minutes or something that's interesting. This is a little bit more about me. You already saw some stuff, so that's not very different. You heard some stuff. If you're not familiar with the National LGBT Cancer Network, just to tell you briefly, we really focus on educating our own communities about our cancer burden disparities, how to reduce those, advocating within the mainstream cancer communities like cancer support centers to make sure that they're actually reaching our populations, and then also training providers and policymakers and things like that on how to do a better job about being more welcoming. Just so you know, we have a whole bunch of great newsletters that go out. We have a whole bunch of great things on our resource library. We encourage you to visit our homepage to sign up for the newsletters. We are at cancer-network.org. And also, if you're an organization, we encourage you to become free members. All we ask is that you either commit to doing a better job with our communities, and or if you are already doing a good job, committing to sharing some of your information to help bring others along. This is just a couple examples of the kinds of things we have on our online resource library, but we're adding new stuff all the time. If you have outreach materials or anything that's aimed at the queer population, we'd love it if you can share it with us to put this up so that we can, again, help other people not have to reinvent the wheel every time they're doing something. So I mentioned a little about that idea that there are some changes in the field, which is making this a little bit different. People might be familiar with the fact, I think a lot of people these days are starting to see some of these different pride flags. So I threw some of them up there on top. Some of the pride flags I just see just as examples would be the Philadelphia pride flag, the bi pride flag, the lesbian pride flag, trans, gender non-conforming pride flag, things like that. And so let's talk about a little bit, why do we have such this kind of proliferation of some of these different identity labels and people dialing down into some of these different areas of identification in our communities? Well, first of all, one of the big trends that we've seen recently, and I've been in this field for a long time, and truth be told, this is probably one of the biggest shifts that's ever happened in my adult life. And that's that the number of people who are identifying as queer is changing very rapidly these days, to the point where most recent Gallup poll, which is a full probability study of the US population, says that for the overall population, it's up to 7.1%. But when you look at generational differences, it really starts to get stark there, what's happening, because this is from that same study. We're only looking at adults, but if you notice that top bar there, over 1 out of every 5 of the youngest adults, which are Gen Z, are currently identifying as some type of queer. That's really fascinating and a complete difference from where we've been for quite a long time. Just to show you the concept of how that pace of identification is changing, I put together my own little chart, which I enjoy looking at in case the news ever gets me down, that if this rate of change continues at this pace, then you can see that by about the year 2054, something like that, 100% of the population would be queer. And by the year 2060, about 180% of the population will be queer. So as I always like to say, I hope they fix math by then to make sure that that can really be the case. Of course, this isn't, real, but I am noting and pointing out that that rate of change is very stark and something we have not seen. It's not usual business. And so that, I think, brings up a lot of questions about, as people who care about serving this population, does that mean that we're still doing business as usual when the world is not currently at business as usual? Another big trend and change related to this is that of the youngest people who are identifying as queer right now, again, I'm a trans guy. We used to kind of be the unicorns in the queer world, few and far between. You would rarely meet us. We were the least common of anything. That's really shifting. Right now in the queer world, almost 50% of our youth who identify as some type of queer are identifying somewhere on the gender non-conforming, non-binary, or trans end of the spectrum. So that is, again, another huge shift. And for us as providers, or for people who are providers, I'm a researcher, not a provider, that brings up a lot of questions about how well are we tuning our work to these people who may be coming to our door when, for example, if the first thing we ask is, are you a man or woman? If that question doesn't fit these people who are non-binary, how early are we going wrong? and how do we get ourselves back on course, and how do we make sure that all sorts of things in our practice are actually welcoming for this population. And then you can also see there that little inset down there that also a huge percent of this gender nonconforming population are reporting discrimination based upon it, and that's as youth. We also know that anything that happens when you're young has a bigger amplified effect on your health throughout your life, so that's particularly challenging. So what does this mean as an upshot? That there is kind of a wave of increasing number of LGBTQI people who are already either talking to us in our practices or will be coming soon. So if we want to do good business and do a good job of actually serving the people to come to our door, again, one size fits all in business as usual is not going to be working for very much longer. For many people, it's already a real failure today. Just some other notes as far as the demographic trends, and again, some of the things are shifting in the population. Another thing that I think is really important to note is that our population is much more racially and ethnically diverse than the general population. You can see here it's almost twice as much. 42% of our population identifies as a racial or ethnic minority. So when we think about this concept of intersectionality and making sure that when we tailor materials, tailor resources, tailor behaviors, things like that to different populations, it's really not optional in the queer communities. You need to start from that basic lens if you're going to do a good job of serving us. So another thing that really, you would think that politics and health don't necessarily interact a huge amount. Well, maybe we do think they interact a huge amount these days, but there is one aspect of this that really is affecting our population, and we're carrying that stress, that strain, and those increased health risk behaviors and things like that that we use as coping skills into health providers' offices. And that's that every single year, every single legislative session, we are now setting new records for the number of anti-queer bills that are being introduced on a statewide level. So, in California, there is full LGBTQ civil rights, non-discrimination protections, but that still doesn't mean that we can't have some of these other kind of bills be introduced. And unfortunately, each of our states are not an island. So when you are seeing queers who come to your door, we are seeing this news about this historic level of anti-queer legislation being introduced all around the country. And then, unfortunately, we see how that also affects, in many cases, our mistrust of the medical system. This is an example from the great state of Florida. We were really happy that the Florida Department of Health tobacco control section started to reach out. And as you can see there, they are one of the sponsors of one of the Pride festivals in Palm Beach the other year, just last year, actually. But the problem is, this year, that same Florida State Department of Health, supporting one of those anti-trans legislative bills, decided to put out a position statement saying that health affirming care for trans youth was actually not medically indicated and was harmful. Of course, they skipped places like the American Academies of Pediatrics and the American Medical Association, the American Psychiatric Association as their references. They instead went to places that I didn't even know exist, like the Catholic Medical Association. But the state of their science aside, the important thing is we now see a whole state taking a stand saying that what we understand from research is life-affirming healthcare, which can drastically reduce suicidality rates and things like that for members in our population, is bad and should absolutely be banned. And again, whenever we're talking youth, it has a bigger effect on our full life course. So these are the kinds of headlines that we're seeing whenever we read anything about queer news anywhere in the country. So even if we're in a state that protects it, unfortunately, this is the wallpaper of the world that we're living in right now. And many times it means that we also are more mistrustful of providers. We know that these things have direct effects on our mental health. And one of the things, long ago, we saw research showing that before there was even this kind of wave of anti-queer legislation, if there was one anti-queer law that was introduced in a state, they actually were able to measure that the mental health of the people, not just in that state, got worse, but the people in the states around it also got worse. So if that was the case when we used to have one bill introduced every so often, what does that mean when we now have basically wallpapering of these bills end to end in our country? We know that it affects youth mental health. We also know that there's the number of youth that are talking about how it affects their mental health. And just to be clear, when we're talking about this population, for example, trans people, usually on average, over 40% of us have attempted to commit suicide at some point in our life. Imagine being part of a group, if you're not already trans, where every time you see any two other people who are part of your group, one of you has tried to unalive yourself because of that incredible stress of the negative stigma from the general population that you see. And so, and just as an example, these are the scars from one of my many suicide attempts. So we live in a world where we have a lot of people who are really struggling as mental health effects with some of these societal expectations and the burden of the discrimination. But you also see, here we have a youth survey that came out pretty recently where the incredible percent of these youth talking about how these new laws are really affecting specifically their mental health, including 85% saying it's affecting it negatively among the trans population. We also know that non-discrimination laws increase and improve our physical, economic, and mental well-being. So just as an example, again, this is a survey that was done talking about what discrimination, what kind of effects that has on our mental health, things like that. And it also talks about the number of people who experience discrimination in different kinds of scenarios. And if you can see that second thing down there, you see that for following or at a doctor's appointment, you can see that the percent of LGBTQ folks who experience discrimination, including that there was bias, including that it was they were blamed for health problems, they were denied or refused care, in each one of those scenarios is much, much higher than the non-queer population. So a lot of what we walk into, let's put it this way, if you're not talking with a queer person themselves who's directly experienced it, it's almost impossible for that person not to have someone in their immediate group of friends who has experienced it. And associative trauma is big for any population. In our population, this is very salient. So even if you might say, oh, something, we protect LGBTQ men, we protect LGBTQ health in California, and our practice is welcoming, what I need to convey here is you're still dealing with a population that comes to you traumatized in the first place. And so that, I think, brings up some good questions, is what do we do to counter that and show that we're not going to be an ongoing part of that trauma when they walk into our practice? So just to give kind of a little bit more of some of this, what world we are living in before we walk to your door, another thing we also see is that this was the other year, this was a really exciting thing because we were tactically closer to getting nationwide non-discrimination protections than at any point in my life that same year. And it was really cool to see this big, summit happen on Capitol Hill about potentially passing nationwide non-discrimination protections. But just because we bring everything back to cancer, look at one of those 3 sponsors is Philip Morris International. So we love this idea that, we're making great strides in some ends, and then cancer comes riding right in on the coattails. And unfortunately, that's a piece of what you'll see as far as kind of our bigger factors that we have related to cancer. Another thing that I just think is a shifting trend in our population right now, these are all pictures from the Cancer Moonshot launch event. And it just really strikes me that, with, Dr. Biden, with President Biden, with Kamala Harris and her husband, sorry, oops, that was a little Freudian slip, her husband as well. We've got more people who are directly impacted by cancer in the executive branch right now than I can ever remember. So that shows, I think, great potential promise for what we might do as a nation to reprioritize cancer and address some of these risk factors which really can be changed. All right. So the next thing I just want to kind of go over briefly is, so what are some of those reasons why we're more likely to go see oncologists, unfortunately, than the general population is? And if people aren't familiar with this little random school supply picture up here, the reason why this picture is kind of notorious is because practically half those items up there are e-cigarettes, all made and designed to look like school supplies so that parents don't know that their kids are using e-cigarettes. So we know, actually, we have a long history. We know more about this history in California than in many other places of the tobacco industry specifically marketing to us. Take pride in your flavor. We saw a lot of this actually happen. It started in the 90s. And like I said, California is one of the places where we knew the most about it, including the tobacco industry reaching out and buying huge amounts of ads in our media, specifically saying, you know, they would ask our own advisors, what's a good message we can give the queer community so that they don't vote against, in that case, it was a smoking ban, right? Or a smoking tax, I think it was. You know, there's been these kind of bills that come up a lot, you know, whether the tobacco industry wants to sell something that, you know, is cancer causing, and what does their general population think about it? And what our advisors said, you know, you got to come up with messaging that builds off of our existing civil rights battles. Like, for example, whenever someone says, dude, that's so gay, we'll be there. That is actually a quote from a Lucky Strike ad. Or there was another one that said, freedom to live, to love, to breathe, to inhale, it's all good. So, you know, that whole message is great, except for the to inhale, except for the smoking freedom message they kind of snuck in there, again, on the coattails of our civil rights battles. So the tobacco industry is really clued in to the challenges that our community is facing. And, you know, the real question is, how long is it going to take for the health industry and the healthcare industry to also be as tuned in to the kind of particular messaging we need? This is just some more examples of more recent sponsorship that we see going on in a lot of pride parades and things like that from the tobacco industry. Oops, that one is a repeat. So we've created some resources to try and counter some of these things and hopefully educate more of the queer communities about this connection. This is just one little one I will play for you.
Hello, my name is Spike. I'm a queer Latinx multimedia artist and performer. I am 34 years old and a native Angelino. I started smoking at a very young age. I was 12 years old. I stole my first cigarette from my father. It was a cool menthol. I started smoking because everyone around me smoked. Everyone I looked up to smoked. I was a premature child, so I was born preemie with underdeveloped lungs. I developed asthma. I'm now on 2 breathing inhalers and 3 pills that I take daily for my breathing and my asthma. That is due to smoking for an extended period of time. I'm more out of breath. I can't dance as long. I can't perform as long. Smoking tobacco does have long-lasting effects, and I'm here to tell you that. So that is my story. That is my view. That is what's happened to me. So I hope I can shed some light on that for you today. Thank you very much. Hello, my name is Spike.
Keep going. Thank you, Spike. We appreciate that. So that's an example of the kind of things we do, because unfortunately our communities don't even understand we have this big smoking disparity compared to the general population. Here's some other examples of the kind of promotion that we do, again, to try and help our communities understand that we use menthol at higher rates. We use the flavors at higher rates. We obviously use cigarettes at higher rates. And in most cases, we don't even realize it's a health disparity. So that's, you know, tobacco is kind of the biggest precursor there is, obviously, to cancer itself. So now let's look at cancer specifically. Some of the stuff I'm going to be bringing up now is from the survey that we conducted about 1.5 years ago, which is the biggest known survey related to queer cancer survivors. We had about 2,700 respondents. Just to give you a sense of the kind of stories that people talked about when they got into care or were trying to get into care.
Throughout sessions 1 and 2, we've learned the importance of listening to LGBTQ+ people, asking questions, and not assuming you know all the answers. Assumptions can be extremely dangerous. Listen to this story from one of the surveyed patients.
My primary care physician was aware of my symptoms 4 years prior to discovery of anal cancer. She detected blood during a prostate exam and gave me a prescription for medicated suppositories. The bleeding went on, but would lessen with suppositories. It wasn't until my husband made me go in that we discovered my tumor was the size of a golf ball. I asked my doctor when I was done with treatment, why didn't she send me in earlier for a colonoscopy? She said she thought the bleeding was from gay sex. We had never even discussed anything like that prior at any time.
And now in kind of a similar story, let's hear from one of our other survivors talk about the kind of the same common challenges related to even getting diagnosed and getting heard from your provider.
So I've been living with HIV for a number of years. And you would think that the one place that a gay person would be affirmed and really cared for was at the HIV clinic. Well, that didn't happen. It actually took them about 9 months to diagnose my cancer from my first initial complaints about having pain on my backside. I got all types of reasons for them not seeing me. Well, you know, come back to your next appointment in 6 months and take these pain pills. So I dealt with that for probably about almost 9 months before I finally got a nurse practitioner who, after I told about my issues, called me in and did a rectal exam. Now, if I'm complaining about what I think is an internal hemorrhoid and you're treating me for 9 months, like, somebody should have done a rectal exam by now. I've literally had more action on the first date. So
Tony is always amusing, definitely. But you know, unfortunately, this is a theme we found, and one of the challenges was not only getting providers to acknowledge people, but also it was really hard to find some indication that a provider was welcoming. So, you know, I just talked to you. I had a bunch of information about how hostile the world can be for us right now. Yet, despite that, only 12% of people who are going to get cancer treatment were able to find any indication that the provider was particularly welcome to queer people. And then a lot of them talked about this idea that they had to go through a lot of steps in order to find a welcoming provider in the first place. These were some of the interesting strategies that people used. And you can also see that, sadly, even the NCI designated cancer centers, what we might think of as best in the world, only 47% of them, only a little over half of them have any findable queer non-discrimination statements on their website. So in absence of that, these were some of the interesting strategies that people used. Sorry, I meant to go back to that. In order to figure out, is it going to be safe for me to get cancer care at your office? We also see, you know, other kinds of things. So I'm a trans guy. If I see this and yet I need to get treated for uterine cancer or something like that, this is where I'm left with going. And this is, of course, at one of the world-class cancer institutes. On the other hand, sometimes we see better things happen. Sometimes this is during Pride Month only, but hopefully it's all throughout the year. We actually did a big analysis of NCI designated cancer centers this last Pride Month. And it was really interesting how many cool things we found. Like, you know, when they light up their whole tower in queer flag colors, that's kind of great. But the sad part is that like 35% of them we found absolutely zero on their website or even during Pride Month. So again, let's get a sense of how treatment goes.
Fear of discrimination is a real and reasonable concern for many of us, especially among our transgender, gender nonconforming, and racially diverse community members. Discrimination can negatively impact our cancer diagnosis and treatment experience. One of the surveyed patients shares her story.
I was first diagnosed with cancer at age 17. My care was great and respectful. I developed cancer again at age 27. I noticed a significant shift. My doctors were dismissive. They often delayed or deprioritized testing and failed to inform me about various treatment options. And when confronted, they were hostile and immediately dismissed my questions and research. I was made to feel it was your fault, probably from such a reckless lifestyle. I lost my shit. They repeatedly insinuated that I used crystal meth and other party drugs, despite being a teetotaling cat lady. I have repeatedly encountered oncologists, radiation techs, nurses, and primary care doctors who are impatient, seem offended, or are openly hostile to me when I'm alone at appointments. When my brother, father, or husband attends with me, it is a completely different tune. They immediately act surprised that a trans woman has a husband, dad, or brother who cares for them. All in all, cancer treatment has been the absolute worst setting for hostility, transphobia, outright aggression, and violence. I have several times had my genitals examined, fondled, or catheters inserted without my consent. And when filing complaints with hospitals have been dismissed outright, despite many of these instances being unnecessary or prurient to satisfy the curiosity of the doctors.
Sadly, this is also
Fear of discrimination.
Sorry, it always does that. This is also a real theme we experience. I'm gonna show Dana's too as another way to talk about how being trans and having cancer care is sometimes a bad interaction as well.
So in 2015, I was in the process of scheduling surgery, top surgery, to begin transitioning. And in May of 2015, I doubled over in pain, and it turned out I was dealing with cancer again. I'd had a reoccurrence. I started talking to my primary care provider in 2016 about the possibility of taking testosterone to continue with the transition process. So he got back to me a while after I initially asked him to do this, and said that in talking with the endocrinologist and my oncologist, I was a little surprised about that they decided that it was best that I not take hormones, because they didn't have enough research or information to know the impact of testosterone on the kind of cancer that I have. I'm now in a place where that's stabilized, and because I'm taking medication that seems to be working. So I'm grateful that I'm in a stable place in terms of my health regarding cancer, but at the same time, I continue to be very sad and disappointed that I can't continue with this transition.
Sometimes our challenges are not even necessarily with the providers, but the fact that there's not enough of a base. Because, for example, if you're not collecting sexual orientation, gender identity, and intersex data on an electronic health record, then you're part of the reason why we're not in cancer registries, because that's where those data come from. And because we're not in cancer registries, researchers have a hard time even justifying to NIH, a very competitive funding environment, doing the kind of research that will get answers to those questions. You can also see some of the other quotes we haven't put into animations here of some of the thematic issues we found. An idea that we wouldn't care about fertility preservation as we went into cancer treatment. This is one of the ones that always makes us laugh. But this idea that also that providers wouldn't necessarily know about sex after cancer for us. We also see this a lot with anybody who has anal sex. If you've got prostate cancer, then you're asking, what's that going to be like for sex after? And anal sex is not the same as vaginal sex, but many providers just like, I have no clue. And this is a sneak peek at what is coming from our forthcoming analysis, our multivariate analysis of that survey. And the thing that I like about this is this really shows us something that we can change, basically. So what we found out was the people who rated their providers very welcoming were almost 7 times as likely to report being very satisfied with cancer care. And again, the great thing about this for us is you can become very welcoming pretty easily. It doesn't require a lot of changes. So if you're looking at doing a better job of creating positive patient outcomes and stabilizing the mental health of this population, addressing that how welcoming your office is a critical variable. And nicely, again, it doesn't require big changes to do it. We're going to go through some real strategies in a couple seconds. Oh, no, sorry, by that I meant right now. So the strategies here, I'm going to go through, I think, 8 of them or something like that. And some of them are kind of organizationally based, some of them are individually based. So there's kind of a melange for, wherever you might be as far as being in the cancer world. But just to go through each of them, the first thing is I'll give you an example of someone who's done it. Spitfire Strategies, they are absolutely great. We love them. It's a communications firm because what they do is one of the most powerful things that can happen these days right now. And that's they ask all their staff team to put their pronouns on their emails, on their Zoom, and to introduce themselves with their pronouns. Understand, if you're not familiar with pronouns, it does not mean you're queer. It simply means that you understand that a segment of the population that you care about has experienced profound discrimination, stress, and unrest because people have presumed to know pronouns and misgender us. I spent most of my life being misgendered. It is not pleasant. And so when you put your pronouns out there, what you're saying is, I understand this is a huge problem for some people. I don't want to be part of that. And you open the door to other people telling you what their pronouns are, especially if their pronouns may not be the ones you presume by looking at them. Next up, we're going to give some praise to UCSF. Actually, that is this poster over to the right here. What kind of flags of welcoming are you putting in your physical locations? So this is this UCSF poster. You've seen versions of this in a lot of places. The one thing I'll say about this is I think it's sad that I'm more likely to see a poster like this in my bakery than I am in my health provider's office. And what does that say? That somehow my bakery is more interested in making sure I have a welcoming environment to buy a croissant than my healthcare provider, where I'm going to get naked and spread my legs or something like that. So this is a place where we have a lot of improvement to go. Next, American College of Radiologists, really excited by that because they have decided to launch a whole campaign where they create a bunch of tailored resources, both for people who are coming to a radiologist's office, for the people who have to go, and it's such a key area related to cancer screening and evaluation, of course, but then also for their radiologists to make sure that they're doing a good job with the population. And then Moffitt, we love that they are doing such a good job at, and they're one of the cancer centers, they happen to be in Florida, of queer data collection. As I said, if we don't get data collection into EHRs, it'll never get into the cancer registries, permanently kind of binding our hands as far as being able to get the research and interventions we need to change our health disparities in this area. Okay, 4 more power moves. What's NAACP doing right now? You may have heard that FDA is looking at banning menthol, and we hope at some point they might consider banning all flavors, particularly these e-cigarettes. But speaking up related to that is really, really important. And don't be swayed by some of the noise that the tobacco industry is buying to put into the equation. Whenever anybody is looking at banning flavors, they're never looking at having any consequences for a user. They're only looking at stopping the access pipeline. So again, the tobacco industry would like to, they're sadly, funding like George Floyd's relatives to say it's going to cause more violence against Black people, but that's noise they're adding into the equation. That is not actually the consideration of places like NAACP that really care about these issues. All right, what's Sinai Health doing? They're not just collecting data with the population, making sure they're welcoming of the population. They're also doing additional research with the queer patient population. Despite being hugely welcoming, they found out that the trans people in their patient community were 40, 50, and 60% less likely than their other patients to get, I forget the exact order, but it was breast, cervical, and colorectal cancer screenings. And they realized they had a problem with reminding for some of those screenings for some of the people, but obviously everybody has a colon. So it speaks back to this idea that we also need to make sure that when we hand someone to a referral, that we do maybe what Cal and Lord does in New York, a big queer FQHC. They, as a provider, call the person they're referring to make sure they're going to be welcoming to the queer person they refer to them. And then they check back in with the patient to make sure it's happened. So whenever you've got that referral and we have to face finding another provider that we may be getting naked in front of and being very vulnerable in front of, it means we've got 1,000,001 reasons to put it off. I speak from personal experience there. So what's HHS doing? Health and Human Services, they have a sexual and gender minority health task force. If you're a big health organization, you should absolutely have this. You do a lot of DEI work, we should absolutely be woven right into all that DEI fabric. What is Cleveland Clinic doing as one of their power moves right now? They have even created an office of LGBT health in that cancer center. So all of these are ideas that you can take back to do a better job with the population. We talked a little bit about pronouns and the number of people who are non-binary, things like that these days. So I'm going to, just a second. Yeah, I'm going to take just a second and play one of these videos so you can get a little bit of a sense of how to use some of the unexpected pronouns. Nope, not that one, this one.
Have you met my friend Alex? They're going to be at the party tonight. No, I don't think I've met him yet. Oh, Alex isn't a guy. Alex is non-binary. They use they, them pronouns. Like they, them, theirs? I'm not familiar with using those pronouns. What if I mess it up? Oh, thanks for telling me that. Do you want to practice before we go? You won't judge me for getting it wrong? No way. I practice all the time. Here, I'll give you some examples of how I would use Alex's pronouns, and then you can try. My friend's name is Alex, and they use they, them, theirs pronouns. They go to school with me. Their partner's name is Sarah. Alex loves dogs. Their favorite breed is a German Shepherd. I'm nervous. Okay, why don't you try using Alex's first name, their proper noun, and then we'll move on to their pronouns. Okay. Alex seems really cool. Alex goes to school with you. Alex is going to be at the party tonight, and I'm really excited to meet Alex. Great job. Now practice filling their first name in with their pronouns, they, them, theirs. Okay. They're going to be at the party tonight. I'm excited to meet them. I think they're going to be really cool, and I hope they like me. Great job. I think they really are going to like you. Okay, but what happens if I mess it up? Here, I'll show you what a mess up might look like, and then you correct me, and I'll show you how I would respond. Oh, look, there's my friend Alex. I like his shoes. Their shoes. Oh, you're right, I'm sorry. I like their shoes. Thank you. So I would apologize, correct myself, and thank them for correcting me. Yep, and then you try not to do it again, and you practice whenever you can.
So it's a great, minute and a half kind of summary of how to do some of those things, which I know are maybe confusing a lot of us. I really would encourage people to practice, and sometimes practice by having imaginary conversations until you get a little bit more easy with the idea of using a pronoun that may be unexpected. All right, so the last thing I want to close with before we're going to get to all these questions, which I'm sure you're putting somewhere. Oh, I only see one question in Q&A. Oh, that's terribly disappointing to me. All right, you're going to give me more, right? Please just do that one thing. Is that I'm going to throw out some resources. We've been creating a whole bunch of new things. We're doing our best to madly offer more resources that we give away to free. And if you are a member, you can also put your own logo on these resources. Remember, as I told you earlier, membership is absolutely free. So I encourage you, become a member, but please use these resources, because imagine us, we're like a place that sells gardening tools, but we have no land. If you actually see people who have cancer and who might be queer, you're the ones who have the gardens. So we want you to please use the tools. Okay, the first thing is we have this great website that helps educate our own communities about the fact that we have a tobacco disparity, how that is connected to cancer, and what kind of resources are out there that we can use in order to try and go through cessation attempts. This does not teach anybody how to quit smoking, because we understand there's a lot of customized, tailored, high-end cessation resources out there. It just takes us and gives us a tailored front option to look at some of the things that have particularly affected our communities so we're more educated, and then encourages us to go out and use other cessation resources. Next, we're really happy that last year we debuted the first that we know of right now, at least in the country, page related to being trans and having cancer. So that is on our website, and you can link to it on your website, on your information page, follow up, everything like that. Third, we are super happy that we've been running for about 1.5 years now. These virtual support groups, they're the first we know of in the country that are for any kind of queer person with cancer. They happen currently 3 times a week. They are absolutely free. But again, no one will know about them unless places like you actually promote the fact that they exist. So what you see here is a flyer. And again, if you're a member, you can also put your own logo on this flyer, or you can redo it, but please tell people that these free support groups are out there. Many people talked about needing them and wanting them. We talked a few different times about how there's this idea that providers don't even understand what sex after cancer is like for our population. So we made a page about that too. We made a microsite about that too. And again, this is something you can provide people in their survivorship care plans. This is something you can look at and learn more about yourself. This is actually Daniel Garza, one of our dear friends who is in LA. As a matter of fact, he is LA based, and really an amazingly brutally honest, forthright, and hilarious survivor who does a great job of kind of really breaking it down. His story is on there among a bunch of others. And then you saw in some of those videos, the cartoon videos, that it said, you know, you've gone through part 1 of blankety blank. Why was it saying that when it was the only video I showed you? It's because they're all excerpts from this big training program. So if this hour is kind of teasing you to maybe learn more about the population, then the next step is absolutely dive into this. It is, you can take up to 5 parts for anybody who's in cancer, the first 5 main modules. If you're specifically in trans gyn-onc care, there's 3 extra modules just for you. But the first 5 are really for anybody in the health world, honestly, who is serving queer people, to give you more in-depth orientation about how to do a good job serving our population. It's completely free, full CEs. It will be free through the end of this year, and you can reach it at that website right there. And then I also just want to say we have a new thing coming. It has already come because July 2022 was passed, and that's our Cancer Leaders Like Us program, or CLUE for short. And this is focused on supporting early career people who are either BIPOC and or queer who might be interested in going into the cancer arena. Because of course, if we want to see a set of cancer providers as diverse as our population, we're going to have to nurture people from a younger point in their career. And this is our attempt to do that. So if you know anybody who falls into any one of these categories, please have them get on there's a sign in our website. Again, that's cancer-network.org, as you see right there. There's a little sign in if you want to be on our mailing list, and it asks if you're one of the people who might want to especially get information about this program. We also have a brand new colorectal cancer toolkit. So this has resources for people who are interested in looking at their risk factor all the way through to treatment. Please check it out on our website. These are some, we also have like cards, things like that, educational cards you can put in your office, especially if you're trying to make your office materials be more queer welcoming. It's a great option. And with that, we are on to question and answer time. How did I do my time? Oh, yes, I'm really close. And if you are a fan, we encourage you to please leave a review actually at Great Nonprofits. If you think that this has been educational or helpful for you, that would be super lovely for us. And I think that scan code gets you there. And then with that, I think the next thing is thank you from us, and we are moving over to the Q&A section. I'm gonna stop sharing my screen.
Okay, thank you so much. That was a wonderful talk, Dr. Scout. Really appreciate you adding that last mentorship piece, right? Because we do need an increased research focus on sexual and gender minorities. And, I'm glad that there's now an office for sexual and gender minority research, but we don't have enough researchers that are from the community, right? The whole idea of nothing about us without us. And so I love
not
that
at the table, you're on the menu.
Exactly. So I'm going to be sharing that. And so we have some questions for you in the chat. And so the first question is, first of all, it's a compliment, amazing talk. And they're saying, I'm curious about what comes first, the messaging or the practices. I would love to have all our staff at our organization put pronouns in their signatures, etc. Tried this with limited success. Put up a sign like the UCSD, but I'm worried that our internal practices don't necessarily create the safe space for our participant population. Doesn't need to be top down.
Well, it's a great question. I think what I see a lot of practices doing in reality is they will send their staff to a training, then they do not follow that up with public facing activities. So if you sent your staff to a training and you have your expectation that your staff are actually going to be welcoming, but you're not checking whether it's patient satisfaction surveys or whether it's that you have, we all have, if there's a grievance, that kind of stuff, that information is out there in a lot of our offices, stuff like that. But if you don't have non-discrimination signs in your office, then how are we supposed to know that there's any of that welcome out there in the first place? So I feel like when you just go to a training and you don't follow it up with something like that gets out to the patients and is also an expectation of the staff, that's apparently the right person didn't go to that training because you're failing there. But as far as which one of those two things is first, I'm not sure we have a lot of evidence as far as which one is better to go first. But I have to admit myself, I think when you set a public expectation in the public areas of your website, your physical offices, and then you also offer people the opportunity to complain if things are going wrong, and you are conveying loudly to your staff, we expect you to do a good job with this. And I'm not saying you would ever do that without also giving your staff the actual resources like access to welcoming spaces or things like that and time to take it. But I do feel like that public conveyance of welcome shows your staff that there is a standard you're holding them to. As long as those people have a clear grievance option, if it doesn't meet that, My suspicion is that is probably one of the fastest ways to create a different environment at your organization.
Wonderful. Thank you so much. We have another comment from a participant that says, this training is amazing. Thank you so much. So
I'll quote them on that. How's that? Thank you very much.
Yes. And our next question is, how would you recommend disseminating these resources you shared?
I think then we got to think about what are the ways that people, you know, that the patients that we get near get any of their resources. Of course, sometimes they're going to get it just by Googling, right? But on the other hand, we do things like we do survivorship care plans. When we're doing that, do we have tailored resources and survivorship care plans? When we see people who are coming to us at the very beginning, like if you're seeing a queer person with colorectal cancer, do you know that there's a tailored resource you can talk to them about so they can learn a little bit more about this? So sometimes we're telling people individual resources. Sometimes we're specifically putting it into something like a survivorship care plan. Sometimes it's that we're putting things on our walls. So I think in that question or in that situation, I would really kind of think of, in your scenario, how is anybody figuring out information? If they're only figuring it out because the providers are telling them, then make sure the providers know about these. And I would also encourage them to make sure they also have tailored resources for all the overlapping underserved populations. Black folks, Latinx folks, everything like that. If we are part of a population that has experienced systemic disparities, then we as health providers should care about trying to do something to offset those disparities, and tailored resources are a key piece of that path. So make sure your providers have the information, or if you put it up on the wall, make sure it's up on the wall, or if in survivorship, make sure it's there. So how do you get them information now?
Yeah. Thank you so much. And having it created by people who are from the community, right? So that it's reflective of them.
Right, which again is why we let you co-brand things, because that way our stuff is on it and they can see that like Queers created it, and whatever organization you're part of is also a piece of it, which helps take some of our credibility with the community and transfer it to you as well.
Yeah, thank you so much. And I'm going to sprinkle in another compliment here. This one says, thank you for your valuable presentation and your ability to make it entertaining. And I completely agree. So our next question is, what are the ways that mental health practitioners can get better at addressing unique psychosocial effects of cancer on LGBTQ plus in treatment?
Oh, that's a great question. And actually, I wish I would have started to speak about this a little bit more. So it's really common in our world. We know from like sociology that we create social support from what's considered 5 domains: where you live, your home, your neighborhood, your work, your family of birth, and your friends, right, are the 5 general domains of social support. Now, as you can understand, for a lot of queers, we may have 0 social support in several of those domains. It may not be welcoming at work. Our family of birth may not be welcoming. So we're over-reliant on some of the other domains. And what we do see related to people who are going into cancer care is that we are more likely to construct our support groups, let's just say ingeniously, right? So you may be more likely to have someone come in and the person that's the primary support person is an ex and the new partner of the ex kind of thing, because that person may not have as much family support as a lot of the rest of the population has. So first of all, we have to understand that our social support paradigms we do not have as much as the general population. And that for us can create an added burden of isolation throughout the cancer care process. And anybody who's familiar with the cancer care process knows that alone is incredibly traumatizing for people, right? So you should expect that we have that incredible added burden. And you should be thinking about, if you're dealing with someone who's going through cancer, what can you do as a mental health provider to help them reassess some of the social support routes open to them? Like, for example, if they're an older person, SAGE is the elder organization, and they have a mental health support line that you can call at any time. Very few people do, because it's hard for us to ask for help, right? But many of us need more of it than we realize. Or do you refer them to these cancer support groups that we have? Truth be told, there's about 100,000 queers, according to demographics, that should be being diagnosed with cancer every year at least. And those support groups still have plenty of availability. So that means that people aren't even understanding that some of these resources are there. So you should expect less social support, all the sequelae of what happens when you go through a traumatizing life event with less social support. And how can you as a mental health provider then be as ingenious as we have to be with creating our families in creating more structures and more assistance for us in that environment.
Wonderful, thank you. And we know that those numbers are underreported, right? Because as you were saying, we're not collecting the data. So
right.
Even those, those estimates we know are underreported. Now, our next question, and you brought up support groups, and they're asking, can you speak more about the support groups offered for people who may be nervous or resistant to joining?
Yeah, so that's a great thing. I think that people are often kind of like, I don't know, I don't want to put myself out there. And some of us are like, please, not another Zoom call. But that said, it's really just a place where you can go and talk about any aspect related to your life. It doesn't even have to be cancer, right? Because it is for survivors of cancer. You do not have to be in treatment right now. I mean, I know people who are really struggling with their survivorship from cancer 20 years after their treatment ended. And they are seriously trying to stabilize themselves. So you do not have to be in treatment right now. You do not have to, you can be long after treatment, or you can be right in the thick of it. But it's a place to come and talk to other people who've experienced cancer who are in the queer communities. It's a place to just bring up anything that's stressing you. It is a safe space where if you want to talk about anal sex, or if you want to talk about, what it's like not to have breasts when breasts were not a big part of your sex life, whatever the thing is, being queer is just the wallpaper in the room that you don't really see anymore because it's a given. And so everybody there is listening and supporting each other. And we've got the people who've been involved with them have been so overwhelmingly positive. And actually they're run by someone who's right out in your part of the world too, as a matter of fact. So it's just basically a free space. If you're trying to deal with the stress in your life and you have cancer, come talk, no expectations. You can be quiet and listen. You can only speak up when you want to.
That's great. And again, another compliment, they said just in all caps, so they're yelling this, fantastic, thanks. Just so you know, that's how great it was.
Y'all are too sweet.
Well, I agree with them, but yeah. So another question here is there a checklist that you've developed that helps organizations determine how welcoming to the LGBT community they are?
It's actually one of the things we've been writing some proposals around, trying to create a toolkit related that for offices recently. So we don't really, we actually, I should say this, we do have an old one that we had created a while ago under a different project. So we could probably pull that back out. I don't think it's well prioritized on our current website, but I could probably pull that out and send it off to the people who are participating in this if you're interested to see it. Yes, absolutely.
That'd be wonderful. Thank you so much for sharing that. And then our last question is, where can we find the tools you recommended?
Okay, so I think everything I talked about is all on our website, cancer-network.org. And you'll see, if you're an individual who wants to get more information, at the top right, it's like, sign up information. And if you want to get more information on a mentorship program, anything like that, it's there. If you know survivors, whenever you get close to the website, there's actually going to be a pop-up on the whole website saying, are you a survivor? Interested in more information? You can sign up there. Or if you're an organization who wants to get that free membership and co-brand things, then at the bottom, there's a become a member part. So any one of those three things you can do. Again, we push out a lot of these tools on our monthly newsletters, and we have a whole bunch of stuff on our resource library. But we have all these microsites that I talked about built in to the actual website, and including welcoming spaces, which is that big state-of-the-art training, which is free at least through the end of this year for anybody who wants to learn a lot more.
Well, thank you so much, Dr. Scout, for shining a light on the very special needs of the LGBTQ community when it comes to cancer care. And thank you for also inviting us, if we have developed materials for the population, to share them with you. You're absolutely right. No need to reinvent the wheel. So I'm hoping maybe some of our attendees have done some of this work and can be able to share it, so that way it gets, there's a broader reach and dissemination, because there's always a huge need. So thank you all, everybody, for joining us. And hopefully you visit the LGBT Cancer Network website to get some of these tools and resources. And for now, we will take our lunch break, and we will be back at 1 p.m. So see you all at 1 o'clock.
Our immense thanks to Cancer Support Community. We know that your motto is, so no one faces cancer alone. Boy, do I know what you mean by that.
Being diagnosed with cancer is one of the most difficult things that a person and their family can go through. The spirit of the mission of Cancer Support Community is that no one should face cancer alone.
When you come through the doors, it is the most welcoming setting. It's like coming into a friend's home. And you don't have the feeling that you're going someplace because you're sick. You're going someplace to be with your friends. And that's what it's all about.
My father's name was Harold Benjamin, and he was the founder, along with my mother, Harriet Benjamin, of the Cancer Support Community, previously called the Wellness Community. Mom got cancer, and they realized that actually going to support groups made such a difference in her recovery. So my father decided that he would create this organization that would really make a difference in the lives of people with cancer and their loved ones. Gilda Radner came to the organization. She was so excited about how this changed her life. When Gilda passed, Gene Wilder and a woman by the name of Joanna Bull decided to start Gilda's Club in New York City. Several years ago, the Wellness Community and Gilda's Club joined forces. We are a community, and we sustain each other through community. Aside from the services that we give, this is a very important gathering place of hope and support for people.
We laugh a lot in the groups, we cry a lot in the groups. I've made incredible lifelong friends.
I did not know that I was going to live. And I met someone in the group who had been alive for 7 years. Same tumor grade, same location, and had been alive for 7 years and had 2 little kids. And I needed the imagination to know that I could survive because I was so certain I wasn't going to.
When I got the news, I think I was numb, and it got really challenging having to break the news to my family because I didn't know how they would take it.
Until we are able to get rid of this disease once and for all, it's nice to know there's a lot of support to help you get through it.
The people that I met here, I will be friends with for the rest of my life. The things that you can talk about are very personal. It's a safe place. When you get in a group, you realize that your problems really aren't that bad. I would not be here today if it wasn't for CSC.
We had cancer. It is true that he was the one who was having the treatment and the existential experience, but in my way, I did too.
I finally broke down and decided to come into a walk-in group. You can't talk to your own friends in the same way because they really don't understand. I need as much help as Linda in a different way, that's all.
I passionately believe that the cure to cancer is not just the medications and the treatment that they give you. And what we found in the support center here is this amazing experience of being able to come here, find all those other things that make it a holistic treatment.
We have 5 pillars of support: groups and counseling, healthy lifestyle classes, educational workshops, social activities, and child, teen, and family programs. All of those pillars work together to create a holistic way of supporting not just the patient, but the family members.
We have calendars that show all the events and classes here. I've taken advantage of the group therapy, one-on-one, yoga, the lunch and learn workshops, educational things here.
No matter how I'm feeling, I pretty much always drag myself on Wednesdays to the writing group. It's a really amazing, supportive community, and it's really neat because it's one of the groups here at the Benjamin Center that can be combined of both caregivers and patients, which has really helped me to understand my partner's perspective through this, hearing some of the caregivers writing.
I walk through these doors and there's Zumba music dancing and people smiling and having fun.
I have discovered the celebration circle. That's a wonderful time just to get together and think about the good things that are going on in your life and to express gratitude and not so much dealing with the cancer all the time. And it's a time to sort of fellowship over good food and good conversation and really having a time of just celebrating the life that we have.
I think that once people find out about this community, I'm hoping that they will be generous with their donation, because everything for the patients here and for the families is free. And we depend on the generosity of people who have the means to give back.
What you do more than any organization in the world is you give a sense of hope. Even if it's just one more day, one more week, one more month.
We really appreciate your donations. We appreciate your concern and commitment to this organization.
I think that's the true definition of love, when you can love someone or do something for someone that you don't know. Thank you.
I just want to say thank you, because it has given me like a family, and being able to connect and meet such amazing people like that in this space is just such a gift. Like, you're really giving people a gift by your donations.
Now that I've gotten through what I hope is the worst of it, I can look back and say that the cancer support community was one of the joys that this experience has brought to my life. So thank you for allowing me to have that experience, for giving me another place I can call home.
Welcome back, everyone. Hope you had a good lunch break. We're going to continue with our Health Equity Summit today. And as a friendly reminder, my name is Mayra Serrano and my pronouns are she, ella, and I'm going to be your roundtable moderator today. So we're really excited to bring you an amazing roundtable that includes incredible experts who will be sharing their knowledge with us today. So our roundtable speakers include Yolanda Whittington with Sister Friends Women's Counseling and Elder Care Management. We also have Dr. Kauser Ahmed with Simsman UCLA Center for Integrative Oncology. We have Ana Rocha with Providence St. John's Cancer Institute. And we also welcome back Dr. Shannon Cava with Cancer Support Community Los Angeles. So let's welcome all our panelists today. So we're going to be here today to kind of have this conversation about, addressing health equity in cancer care. So I'm going to go ahead and start off with a question for the panel. And so let's start off by asking, what is it that your organization is doing in regards to health equity? And if you could, actually, let's start with introducing ourselves. So we'll go ahead and get started. Yolanda, do you mind introducing yourself?
No, not at all. Thank you so much. Good afternoon, everybody. It's a pleasure to be here and participate in this wonderful, wonderful event. My name is Yolanda Whittington. I'm a licensed clinical social worker, and I work for Sister Friends Women's Counseling and Elder Care Management. Did you want me to answer that question now, or wait until all of the introductions have been made?
Let's do all the introductions, and then we can go ahead and hit that question. So next I have is Dr. Ahmed.
Thank you so much, and I'm so honored to be here with these wonderful panelists at this incredible summit. My name is Kauser Ahmed. I am a psychologist, and I've been the director of the Simsman UCLA Center for Integrative Oncology. We're the psychosocial hub for patients and their loved ones and their providers at UCLA.
We're happy to have you. And next on my screen, I have Ana Rocha.
Hello, everyone. Thank you. Thank you, Shannon and Julia, for inviting me. I am a nurse practitioner. I started my career in oncology about 17 years ago as a nurse on the oncology floor in the hospital. And over time, for the last 5 years, I became a nurse practitioner, and all my 17 years have been in oncology. and I'm currently at the Providence St. John's Clinic at Ellison.
Wonderful. Thank you, Anna. And last but not least, we have Dr. Shannon Cava.
Thank you, Myra, and hello, everyone. So I am Shannon Cava. I'm the Chief Clinical Officer here at the Cancer Support Community in Los Angeles. And I am very happy to know all of the wonderful people on the panel, and thank you for being a part of this event. I might not know some of those that are in attendance, so I work here at the LA Cancer Support Community, which is part of the Cancer Support Community and Gilda's Club network. And I've been in this role for about 7 years, and I am a clinical psychologist by training. So thank you.
Thank you so much, Dr. LaCava. So I'm going to bring it up again. So tell us a little bit about what you and your organization are doing to advance health equity. Yolanda, I know you were ready with an answer, so why don't we go to you first?
I'm not sure, Myra, I was ready with an answer, but certainly I will have to go first. So Sister Friends' target population is, in fact, African-American women. That is who we primarily target. That is who we primarily serve. And we serve all Black women and their families and loved ones, irrespective of how they present here at our particular agency. So how we are addressing health equity, since we are a mental health provider, providing individual, group, and family support services, the mere fact that we approach health equity from a social, transformative, cultural, and ethnic lens through the perspective of the legacy of slavery and intergenerational trauma on the psyches and experiences, behavioral health experiences of the women and the families that we serve. And one of the things that we really try to do is A, to create access, B, to be able to have the cultural, competent understanding of their life experiences in the context of the issues that they present to us, and are able to engage them in ways that are welcoming, very warm, non-judgmental, and without necessarily having to explain to us who they are and what their experiences have been. And in that way, they feel that they are affirmed, valued, they feel a sense of worthiness, and are very appreciative for having to be able to come to a entity that is well aware of their cultural needs and accepts them unconditionally where they are in their journey of health and well-being. Thank you.
Thank you so much, Yolanda. Would anybody else like to share?
Sure, I'll go ahead. So one of the ways that our organization is promoting equity in care is by identifying barriers to care and creating and piloting programs to address these issues to help make care more equitable.
I'm happy to go next and just add that UCLA over the last 5 years has really made efforts to bring exceptional oncology care to people in their home communities. We all know how difficult traffic is in the greater Los Angeles area, and what a difference it makes when you can go to your oncologist, get access to clinical trials, all of the exceptional care in the region that you live in. So UCLA has 20 clinics as far south as Laguna, as far north as San Luis Obispo, in Ventura, Santa Barbara, Torrance, downtown LA, Laguna, I already said Laguna, Porter Ranch, Burbank. What that also has meant for us as we have scaled our psychosocial programs along with the medical oncology care is that we've really attended to and wanted to honor all the various dimensions of diversity and issues of access that exist within that broad geographic footprint. So we have made sure, as we have brought on more clinicians to our team, wherever possible, they are from within the home community, that they speak like the language of folks within that community, if it is a language other than or in addition to English, that we have partnered with grassroots organizations who have been doing this work for many years, and really learn from them and enhance what they're doing, rather than just reinventing the wheel, making 2 and 2 be more than 4. So I'm really proud and pleased that we now have a staff that has grown up in geographically remote places like San Luis Obispo, went to high school in Alhambra, and they're now the clinical leads there. We have a team that speaks Farsi, Armenian, Cantonese, Vietnamese, Spanish, of course. And that's just one dimension, right? We're recognizing that diversity, ethnically, linguistically, is one aspect of providing sound, culturally congruent care. But other aspects really have to do with equity and access, and things that are on a broader plane that come from, as Yolanda very rightly and so eloquently said, come from a history of discrimination, come from a history of racism and injustice that was in the past, and the generational trauma of that, and what's in the present. So really trying to understand all of those components, and I'm sure, like Anna's program, trying to meet the needs where we can, and do so with humility, recognizing that we know what we know and can bring what we can bring, but it is not everything. And we need to learn from the people that we're serving, and the folks who've been on the ground doing the good work.
Amazing. Thank you so much for sharing. Shannon?
Yes, I can add, and really just everything that Yolanda and Anna and Kauser shared, it really resonates. And I think that is also why collaboration is so important for us, because we are learning and working together. And I'm just really thrilled for CSC Los Angeles to be able to be working with each of you and your organizations. Part of that came from naming what we were doing in this collaborative space. This is really our heart initiative, which is healing equitably through action, resilience, and teamwork. And it really highlights how we don't do it alone. We need to do it together. And that's part of the expansion that we've had on our staff to be more representative of LA and our LA neighborhoods, as well as our Cancer Equity and Diversity Committee. So how can we learn and grow with the inclusion of those in our communities, so we can hear what the needs are and modify where necessary, and work together where we can to meet those needs. And I would say our Health Equity Summit, we're really excited to have this, but I really want to underscore that this isn't because we have the answers. It's really because we have the platform to put this together to learn from each other. So I can speak for myself, and I will speak for our staff as well. We're learning through these whole 2-day events, because I think it really takes us together to be able to make these strides forward.
Wonderful. Thank you so much, Shannon. And I want to give a reminder to our attendees to please submit your questions in the Q&A chat box, so that you can ask questions of these wonderful experts that we have at the roundtable today. But for now, I'm going to go ahead and get started. And Anna, can you tell us, what is collaborative care for mental health, and how does it work in oncology?
So thank you for asking that question. Collaborative care is something that I became very passionate about. It's actually a specific type of integrated care that was developed at the University of Washington to manage common mental health conditions like depression and anxiety, which we see a lot of in our cancer patients. It's based on the principles of effective chronic illness care. And when a patient is referred to our program by their oncology team, they can be referred at any point in time. The patient would see the survivorship nurse practitioner. I'm certified in both primary care and in oncology, and I'm embedded within the cancer center. And we work very closely with 2 social workers and 1 licensed professional clinical counselor. And we collaborate with the psychiatrist, Dr. Gary Nathan, and provide a real multidisciplinary 3-pronged approach using evidence-based medications or psychosocial treatments. Patients are tracked in a registry along with regular measurement-based screening that we perform, and we treat to target. So that might mean for a patient that they will have access to talk therapy alone or with medication. And what we found in this, using this model, is that patients are able to access mental health in a timely manner. It's effective and it's very affordable. It's much less costly for the healthcare system because there's improved outcomes and ensured access to care. So for patients, again, the majority of them paid an out-of-pocket cost of less than $50 a month for 3 to 4 visits, which includes expert psychiatric opinion, talk therapy, and quality survivorship cancer care. In general, the cost of seeing a psychiatrist or psychologist, we know, can range between $200 to $500 per visit. And I can't think of a better way to afford to provide effective, affordable, equitable mental health care. So that's collaborative care.
Thank you for sharing. That's amazing. And you're absolutely right. Sometimes the cost of getting care can be a barrier for people, right?
Right.
And I know even during COVID, just getting in the door, was difficult because people, weren't taking on new patients, or they just had overwhelmed with requests. So, it's great that you have, working in that collaborative model to be able to provide some of these services. Now, Yolanda, I'm going to ask you a question next. And can you please tell us what successful strategies have you used in your mental health practice to reduce health access disparities for Black, Indigenous, and people of color diagnosed with cancer?
Excellent. Thank you, Myra, for asking me that question. And I just want to thank Anna for her response and all the work that she's doing as a nurse practitioner. Well, there are several steps, I think, practical steps that I think that we take to help increase health equity as it relates to oncology patients that are in need of mental health services and support. The first thing we like to do always is to include persons of color in any planning of services delivery, from evidence-based practices to community-defined practices, or cultural practices or Indigenous practices that are consistent with how they heal. And that may include spiritual practices or faith-based approaches. The other thing we do, the second step, is that we believe in recruiting staff that mirror the clients that we serve in ethnic and cultural and life experience in terms of the composition. We believe that makes the staff relatable to the patients. They're able to make easier connections with the therapist of whom is providing the care, and it also helps to generate positive health outcomes. The third thing we do is that we interview our patients by way of a survey. We believe in doing some outcome performance measures. And through the survey process, what we like to do is to integrate the recommendations of the patients into our services delivery system. And that way it conveys to them that we take action, or we actually act upon what we say. So we are able to, in our actions, create the change in our services delivery system, make the modifications that are requested, and in that way they feel a sense of value and that their voices have been heard and that they also feel affirmed. The other thing that we believe is important is that just because we may be persons of African heritage doesn't mean that we have the necessary training and understanding how the impact of systemic racism and the legacy of slavery impacts healthcare outcomes, behavioral health outcomes. And we believe in using a transformative health justice lens and how we engage the clients that we serve. Thank you.
Thank you, Yolanda, and thank you for bringing up the issue of justice, right? We discuss health equity, we discuss disparities, but all of this is that so that we can also ensure that, we're achieving health justice as well, right? So thank you for explaining, a little bit about what your organization does. So I'm going to move on now to Dr. Ahmed. Dr. Ahmed, can you tell us about the ongoing implementation of the End of Life Option Act in terms of equity and access?
Yes, I would be glad to. I don't know how many in the audience are familiar with the the California End of Life Option Act, which went into law in 2016, was recently modified again. And this is, just briefly, this is the law that parallels, mirrors Oregon and Washington's Death with Dignity Act law that allows individuals who have a untreatable terminal illness to be able to participate in conversations with their healthcare team with a great deal of management and making certain that all kinds of things that keep people safe from coercion or feeling desperate to have to do this, or that they are dealing with untreated pain or untreated depression, that none of those are the issues that are making them consider as one of their options their right to decide the time of their death, and to be able to work with their providers to receive medication that allows them to do so safely and painlessly. It's a complicated topic. It so understandably filled with a lot of emotion on all sides, concerns, fears, worries. And what we've learned since the time that this act has been in place in California, and particularly the way that we've implemented it at UCLA, is the most important element of this act is about access to conversation, not access to drugs. It is access to conversations. So those very needed conversations that truly all patients and their loved ones benefit from, for it, about what their prognosis is, what their remaining options for treatment are, what are the benefits and the costs in terms of quality of life with pursuing that treatment. And for a small select few, and it is a small number of people, if they choose to be able to also have as one of their options the process of becoming eligible for, meeting criteria for, and then receiving a prescription for the End of Life Option Act. So the numbers typically show that this is a very self-selecting group. Typically, overwhelmingly, these are white individuals. Overwhelmingly, they are college educated. They have sort of personality hallmarks of lifelong independence, a sense of wanting to make decisions for themselves, strong sense of autonomy. And one of the questions really early on was, how would other communities, particularly communities of color, communities from less advantaged economic backgrounds, how would they both receive this option as a law, and would they feel comfortable making use of it? And what we've discovered over time, so at this point at UCLA, since 2016, we have had roughly 350 cases of individuals seeking the End of Life Option Act. And some time ago, then the percentage of individuals, so 331 cases in the past 12 months, the Sims Man team has assisted 135 individuals, but those 135 individual cases actually yielded 2,000 conversations. 2,000 conversations between loved ones and patients, between providers and patients, between our clinical psychosocial team and patients about what are their wishes for their end of life quality of life. What do they want as their legacy? What are the things that they are struggling with now that we can assist with if they do not qualify for the act? You have to be at least 6 months towards a natural death without treatment. Over time, we have come to see about a couple of years ago, those numbers were 83% were white patients, about 8% Asian patients, 2% who were identifying as other, less than 1% were African American, 6% were Latino. This year, the numbers are more like 63% are white, 12% are Asian, over 12% are Latino / other, and almost 2% are African American. Enough of a change that I can say it's connected to having clinicians who speak the languages, who understand the cultural backgrounds, who are accessible and available to really have those meaningful conversations about what end of life care can look like and help people to make their best decisions. This is not about advocating for end of life option medication. Actually, the vast majority of people who have these conversations do not get a prescription, and even among the people who do, they say that it just gives them a sense of peace of mind. The number of people who actually ingest, and that is their primary cause of death, it's less, it's in the high teens. But what I see as the good of this act, we have seen it over the last 8 years at UCLA, is truly those conversations that are so necessary, so hard to initiate for everybody, and everyone, every community has a right to that part of oncology care, as well as every other part.
Thank you so much, Dr. Ahmed. And I want to remind the panelists, I know I'm asking questions of specific participants here, but everyone is welcome to add, contribute, your thoughts as well to the conversation, to the question that's posed. And again, friendly reminder to start submitting your questions through the Q&A feature on your Zoom panel. But if we don't have any questions just yet, I'm going to ask a question of Dr. Cava. Dr. Cava, in your experience, how do support groups help reduce racial disparities in mental health treatment?
Thank you, Myra. In terms of the groups that we have here, I think we have a lot of groups that bring people together that the common thread is cancer. And so there might be this component of learning from others that have different either socioeconomic status, race, culture, spirituality, differences in those regards. So it is a platform for individuals to kind of learn from one another. And I think that can be a very supportive component while having cancer care. But additionally, we're really looking to see how we can target groups for specific populations. And I'm so glad Yolanda is on the call because she is just starting. So CSCLA and Sister Friends collaboratively putting together a group, and she just started the Black Women Living with Cancer group. So that also gives space where there's inclusivity, but it can also be targeted because the needs and the conversations, there can be such a safety and a maybe even more comfortable place to get together when the conversation is about cancer, but so much more. So Yolanda can finish with the discussion on that group, but I would say that there's an opportunity to get support and also give support. I think the support group is an incredible dynamic we call ourselves facilitators here, even though we are each licensed mental health professionals that provide the group support or in training to be a licensed clinical professional. But the experts are those that attend. And we are there to just kind of steward those relationships. And I think that gives way for us to follow where the conversation needs to go and to help voices come out that might be a little quiet, and to just really give space. And we really are looking to, even maybe it's not a support group, if there's cultures or communities that might have hesitancy to getting involved in mental health services or support groups, how do we change it? How do we have social events or other events that are a platform for connection? We've done so in the Korean community of having a social, a coffee hour with a clinician present. So those little conversations can happen more organically, to make it a softer entry into group support and mental health. But I think that's how we're doing it. And a lot of it is through collaboration as well, and not thinking that we can do it alone, and not thinking that we have the perfect recipe.
Wonderful. Thank you, Shannon. Yolanda, would you like to add to that? I know Shannon did call you out on that.
She did. And thank you so much, Shannon. I think the world of CSCLA and all the work that they do for persons living with cancer. So Shannon is right. We just started our Black Women Living with Cancer support group. And one of the common themes, or one of the common communiques that occurs throughout that group, is how the women feel connected and how they're so excited to be a part of that group and have other women who look like them, that have shared cultural experiences as they have lived experiences that include inequity in healthcare, and have a safe environment and a safe space where they can communicate honestly and authentically about their feelings of shame, their feelings of pain, the lack of compassion they may have experienced. And they all come together to really rally around each other, support each other, continue to share their experiences that they have in common. And then they also have come together to connect in between meetings as well, and serve as a support system, whether or not a member is trying out a new medication and another member may have information about a medication or that same medication, or maybe holistic practices that they can share between one another, side effects that they're dealing with, other healthy coping capacities that help them in their recovery process. So in that way, they do very, very well. And one of my favorites, of course, is sharing the food recipes. Since we all like to eat. So that's really very, it's very fulfilling, and it brings about a sense of joy to see the women come together in that way. So thank you.
I'd like to add. So for Dr. Ahmed, thank you for talking about the End of Life Option Act. I think it's so incredibly important. But another way that we try to help get out into the community is going into houses of worship to talk about maybe not end of life, but advanced directives, and how anyone over the age of 18 who has the ability to make decisions about their healthcare. So being able to do that and participating in services, webinars, town halls or roundtables in those arenas are very important. And Yolanda, for the groups, I think, tend to be something people fear. I'm not a group person. I don't want to hear somebody else's story. I'm going to come out, more depressed than what I was when I went in. But we actually, brain tumors make up for a very small percentage of the cancer population. And so we actually piloted a brain tumor support group for people under the age of 50. I believe it was 21, 25 to 50. And there was a lot of hesitancy from participants to join, not sure, how it was going to be, but I was it was such a privilege to bear witness to what was shared in those groups and the healing that occurred when you have a rare disease and you seem to be the only one in your family or, in your community. And to be able to talk with other people about it, it's just something that is so healing, for lack of a better word.
May I ask, Anna, are you still running that group?
It's been put on hold for now, but we hope to get that back up and going.
That's a great offering.
Can I ask a question? I know I didn't put it in the chat. I really appreciate Anna and Kauser, you both sharing a little bit in different ways of those end of life options, whether it be the End of Life Option Act or to the point of the advanced directives. And something that we talk a lot here in our groups, we hear the idea of control. So sometimes even at end stage, there's this feeling of loss of control. I wonder if each of you might be able to speak a little to what you've seen either in the research, Kauser, or in the work that you're both doing. Are you seeing evidence of a feeling of control in just being able to have a choice at that stage?
Yeah, I'll answer first, Anna. I think that is one of the really critical things that people who are living with cancer experience, is that sense of loss of control. And I think there are a lot of other words we can use too, because, control is so big. And when we think of it, there's so many things none of us can control, including our sense of vulnerability and what could happen next. I like to think, and we talk in terms of the language of agency, of choice, of decision making, right? That it isn't necessarily trying to get your arms around the bigness of a diagnosis or the outcome of a diagnosis, which truly may be apart from everything that is done medically out of anyone's control. But never is it the case that each individual shouldn't have access to their sense of personhood being honored. Their sense of about what matters. And it is kind of a circle, because what makes that exercise of agency and choice happen is the ability to talk about it with the other people in the circumstances. And I'm sure all of you who have engaged with patients on some level know the sense of people saying, well, I'm waiting for my doctor to bring it up, or I'm waiting for my loved one to bring it up because I don't want to frighten them by being the first person. I don't want to sound like I'm giving up hope. All of these things, I think, the sense of a shared language, respect, love, honoring, and that restoring to whatever extent is possible agency and decision making and choices for the family, and most especially the patient. That is the goal. And there's no question that the literature shows that the people who choose the End of Life Option Act all the way through have a very, very strong sense of feeling like this was their choice. This was how they exercise control in a situation that was beyond them. And interestingly, this surprised me a little bit when we look at what grief looks like in these families. After a loved one has passed, there is so much room for families to second guess themselves. Did we make the right decisions? Should we have done this or that? And there's a real absence of that among these families, because they were there right to the very end, hearing what their loved one wanted, honoring it, having ritual, Yolanda and Anna, in the ways that are meaningful to that family, to that culture, to that person. And while there's great loss and sadness, there isn't a sense of we didn't do what the person who we loved wanted, and we didn't help them to get to the peace that was available to them. That was a very long answer, but yes, your question was very right. And control and ways to understand control it's so at the heart of living with cancer. Yolanda, I'd love to hear from you.
Yeah.
Thank you, Dr. Ahmed. I actually have a question, and probably a few questions, but two in particular. So I noticed of those cultural groups that you listed around those who opted for the end of life option, African Americans resulted in the smallest group. So my questions are this. Question one, what were the contributing factors based on your research that led to those persons having those discussions around end of life? And two, what were some of the issues that they raised within the families or in the patient that they may have struggled with coming to that decision? Thank you.
I will do my best to answer your question, and I'll confess right off the bat that I don't know this literature in such detail to be able to answer specifically about the African American community and their experience. I can extrapolate from what I've read and from what I've seen. I think that the balance is always around wanting to do what's best for them and wanting to do what's best for their family. And families so often want more treatment than the patient at some point really wishes to continue with. And there are many patients, and true in all cultures, but sometimes more strongly in some communities, that to choose not to fight to the absolute last, to feel like you're abandoning how not choosing them. There's a lot of fear and concern and worry that's what they might be imposing on their loved ones. Now, as to the question of, do all persons of all backgrounds get equal access to the right care, and that right care includes full information about all the decisions they can make? I'd say probably not. We know that's not the case. So I could also imagine that in the African American community and some other communities, there's just a question right from the beginning of, am I getting everything that is potentially available that could save me? Right? How hard do I have to work to get access to that? Am I limited by what my local hospital has access to? Am I limited by what my insurance coverage will allow for? So I think those are very, very real and important questions that people, particularly from less privileged socioeconomic communities and regions struggle with first. You have to have a certain amount of feeling like you've had a lot of agency in your life to feel like you can have agency when you're dying too. I hope that's not said too bluntly, but I think it's all part of the same discussion on some level, with layers and complexities. I hope that did justice to your very good question, Yolanda.
Oh, it did. I was actually thinking that in my experience as an African-American woman and working with African-American families throughout the years, including African immigrants and Black immigrants, spirituality and faith play a huge role in their decisions around their life in general and end of life care. I can imagine it would really play a huge role. And I was just wondering if any of that came up and, you know, how
you are so right. And yes, absolutely. I was thinking through the lens of equity and access and completely had blinders to that. Yeah, absolutely. One's spiritual orientation, one's faith is very much at play about how people accept, come to terms with, make peace with, and choices that they feel they can and should exercise at end of life. And faith, as well as lack of practicing faith, play a role. Much more so in the African American community, where faith and community and family are often really tied together.
And I know you had unmuted yourself earlier. I was wondering if there's still something you wanted to add to the conversation.
No, just that when working with people with cancer, you know, if they're coming to you for their first visit, it's a difficult time to, or if they're newly diagnosed, it's a difficult time to ask questions about advanced directives, but really it's not. I mean, I think it's a heavy topic, but the worst thing we can do as providers is assume that we know what the patient is going to say. And so being able to provide them a video maybe before their first visit, generally speaking, what are advanced directives? When they come in for their visit, asking them the question, do you have advanced directives? If they say no, you know, handing them the pamphlet. I mean, it can be done over a period of time. It doesn't all have to be done in that one visit. So I think that's important. And going out into the community, spirituality, houses of worship, I think that's a great place to go and provide that education, because it's not that people don't want to talk about it. There might be some fear about it, understanding of it. They might not know what advanced directives are. So being able to bring that to them in their place where they're comfortable is important.
Thank you so much. And please, you panelists, feel free to ask questions of each other. And again, I'm going to invite the audience to submit questions. This is your opportunity. You have this wonderful roundtable of experts that are available here today to answer your questions. And that being said, somebody submitted this question, and anybody feel free to, you know, take it and add. They asked, could you describe some of the ways you build relationships with organizations in the community, like faith-based communities?
I think first and foremost is to, you know, approach maybe your local community organization, whether it's a house of worship, and just let them know, I am a nurse practitioner and I would love to provide free educational information. Are there any topics that you might be interested in hearing about? And I think that's a great gateway in. By doing that, I kept getting asked over and over and over again. I've spoken on prostate cancer, breast cancer, head and neck cancer, advanced directives, COVID-19, you know, COVID-19 and kids. And I've spoken not just at houses of worship, but Latinos Unidas and, you know, a lot of different organizations. So I think that's just your name gets out there and people then associate you with learning more. So it's great.
I agree with Anna. I think in my case, since the majority of my clients are African-American women, there's also a significant majority of them that are faith-based, connected in terms of connecting themselves of being members of a particular congregation at a particular church. So oftentimes they ask me, would I come to their particular prayer meeting, or can I come to their, new members meeting, or can I speak with the first lady of the church, or would I mind doing a training here on removing the stigma of mental and behavioral health practice, or how do you integrate behavioral health and mental health within, spiritual or religious doctrine. So I usually take advantage of those opportunities to build relationships and partnerships with my fellow faith-based entities.
Shannon or Dr. Ahmed, would you like to add how you build relationships with community organizations?
Sure. Great thoughts from both Anna and Yolanda. For us, because we are geographically dispersed, we had the opportunity to go to different organizations. In fact, Shannon, one of the first things we did was find the cancer support community in all of those regions and reach out and make connections and say, okay, what are the things that you're doing? What do you feel like there are gaps in the community? What can we be adding? It's all about relationships on some level, working with the people that you already know and establishing more connections. I think the only thing that I would say from my personal experience is it's really important, especially if you are the larger organization, right, in the room, that you come with a sense of humility and that you come with a sense of respect and really let the local organizations, the folks on the ground, the people who know the individuals and the challenges better than anybody, that you let them lead and have the primary voice, and you ask, what can we do to help what you've identified, rather than here's what we've got and here's what we're giving you, whether you need it or want it or not, just because. And that goes a long way. It goes a long way to really not just having not just a one-time event, but those relationships that sustain, and you continue to do that. And then there's a lot of mutual collaboration and a mutual sense of these issues and problems.
I would add that I'm learning and taking notes right now, being part of a community-based organization that is really interested in partnering and collaborating. And the next talk is actually about partnerships and how that can look. I would say too, to follow what Kauser was sharing about that equal part component, not coming in that we have the best thing and we're going to plug and play without hearing what needs are first, and vice versa. So reflecting that larger entity component of being part of academia and the larger hospital systems, it's wonderful to hear that kind of invitation, awareness, and acceptance for a smaller organization to come into a partnership conversation, because I think it is about that, coming to the table to design something together with the expertise on both sides, with no one acting as an expert, and the humility. So it was wonderful to hear that. And I think in terms of partnerships and collaborations, it's looking to do those across multiple different systems. Is it with a large hospital? Is it with a faith-based group? And anywhere in between, and finding those that are champions already for either the services that we provide or advocates as patients that have gone through cancer. I think it's really about just seeing the value in so many different people and community members and champions within the healthcare system, and what those relationships can look like. And I think that the stewarding piece is also so important, because we might not be like, let's meet today and do something tomorrow, but isn't it wonderful to stay connected? Because I think things organically come about in that way. So sometimes partnership is slow, but the relationship building can be, I think, even that much better and sustainable.
A last thought that just popped into my head. I know Dr. Jackie Kim was on this program as well, and I'm such a fan of the work she has done, because she really leveraged that being part of an academic medical center, but going directly to local grassroots organizations, multiple organizations within the various Asian communities in Los Angeles. So I would say, maybe look at some research that folks are doing in your area and that it has a community focus, and see who they've connected with, what's already been done on the research level, and see if that points you to some opportunities that you can do in terms of shared joint programming.
Wonderful. Thank you so much for all our roundtable panelists to answering that question. Hopefully the person who asked that has some tips on how to, build those relationships. Now, our next question came in, and it's specifically for Yolanda. Yolanda, the question says, I have facilitated support for African-American women with cancer for years, and I have found hosting activities in addition to the support groups create sisterhood. What are some of the activities you do with the group?
That's an excellent question. Right now, we're still very new, and we're still forming, and we're still gelling and building a sense of solidarity with the participants, and they're still disclosing and sharing where they are on the continuum of their diagnoses. So we haven't yet transitioned into types of activities that we could do, but since this is also a partnership with CSCLA, that is something I would probably sit down with Dr. Shannon Cava and talk about, because they also have activities there in the umbrella organization. So yes, activities do bring us together, brings us closer, and we're able to talk about other things outside of cancer too. So that's very important. So thank you so much for that question.
Wonderful, thank you. And I think that was also in the video, right? We saw that, there's the celebration circle. So it doesn't always have to be something, that we're having to focus just on the cancer diagnosis. But I think I interrupted you, Dr. Cava.
No, not at all. I just was excited because I think it is an invitation to have a larger dialogue about what's needed and what can we do to create that space and have more activities. So I welcome a discussion with Yolanda to see what that can be. And just to give some example of some of how some of our additional services have come into play, it comes from the needs and the feedback that we get from our participants. Case in point, we have a really robust young adult group that when we were in person was very small, and we were about to move it online just before COVID. So it got, fast forwarded because of COVID, and it grew over time to a space that was a very large group. And there was interest in social connection outside of the group and trying to find ways, how would that look, especially during COVID, and the increased access in terms of geography for our groups when they went online. So we created a young adult game night, and we partner with an affiliate in Madison, Wisconsin, and with some other organizations that support AYA and YA cancers. And we have individuals from across the country attending this trivia night and game night once a month. So that came out of that same voice of what am I looking for? What kind of support, what kind of feedback can I give? And we do our best to accommodate. And so it's wonderful, because I think that's where the biggest successes come from too. So I look forward to talking with you, Yolanda.
That's great. And we look forward to learning more about that. But because, earlier on, you all mentioned the idea of connecting, right, with other people. And, that's one of the benefits of support groups, and having the social aspect of it helps with, that connectivity so that people feel like they know each other. So I think that's wonderful. Now we have another question, and this is just a general question for all our panelists. In your experience, What are you most excited about that you see making a difference in health equity?
Well, I'll go ahead and take this. I'm most excited about the collaborative care model for mental health in oncology. I think it's just a great way to be able to access services where you're already getting care for your cancer. It's affordable, it's effective, it's been proven time and time again. So I just hope that more people take advantage of it. I think part of it is the misconceptions, right, around mental health. A lot of the focus is on the physical health, but there's so much more beyond us than our physical, right? There's our spiritual, there's our psychosocial, and how we relate to others in this world. Does that change when we have a diagnosis of cancer? Will I still be able to do the job that I was doing before? How will my family see me? So I think knowing that anxiety and depression can happen when the diagnosis of cancer has been made, and then they go through that process of being on treatment, which can exacerbate maybe something that was previously there, and then waiting until somebody starts to have thoughts of hurting themselves, or that's too late, right? We need to screen early on, and we need to manage early on, because stress on health takes a negative impact, terrible toll, and studies have found a linkage to cancer recurrence and prolonged periods of stress. So it weakens our immune system and our ability to fight. So I just hope and encourage people to get help for their mental health.
I think what I'm most excited about is the Health Equity Assembly Bill 1038 that is sitting on Governor Newsom's desk. Maybe it's not sitting on his desk exactly, but they're still lobbying that bill to create a Department of Health Equity. I think once you have legislative action and a bill becomes a law, then you're able to have funding that is connected to that. And then we're able to hold our legislators and our California departments accountable and ensuring that they meet the expectations and goals of the legislative measures. So I'm thrilled about that. I'm hoping that will pass and pass relatively soon. And I'm looking forward to the outcome of that. Also, I'm excited about the discussions that are happening on reparations here in California, excuse me, and that they have an advisory group that Governor Newsom has pulled together to begin to look at and explore potential reparations. So I'm really thrilled about that, because that too can impact health equity. So thank you for that question.
I'll go next. I don't know that this is something that is the most exciting, but it's something that I've noticed and been heartened to see that at UCLA there is a consistent messaging around the importance of equity and access, that is being introduced into the medical curriculum for new physicians, that there is allegedly effort to really have students and trained doctors who are representative of our nation's diversity, and that both providers and patients are being given a voice to champion the importance of equity, access, respect in their entire sense of wellness, medically, physically, emotionally, psychosocially. The fact that, in a relatively short period of time, we began to understand the importance of gender diversity and respect around pronouns, respect around asking people, what name do you want to be called? That these things matter, that they matter because we are whole people first coming into whatever medical situation we're coming into, and that the need to be treated with that kind of respect. That's layer one. That's the culture of medicine. And then there's everything that Yolanda and Anna have been talking about, which is the systems that have held inequity in place and that need all of our push, every one of us, to change.
I agree with each of you. I would say on a local level, what excites me is just the fact that we're able to have this platform, and that we were 1 day last year and we're 2 days this year. And I think that's because there's such incredible work being done, and we have such incredible presenters like yourselves being able to share this. And I think that is part of this, really having the conversation just grow and impact more and more people so they can do similar work that you're each doing on a more global or larger advocacy level. I would say I'm really happy that and I'm honored to be part of the Health Equity Committee on the American Psychological Association, and kind of rolling out of my current responsibilities, but really seeing more and more coming from Dr. Jennifer Kelly that spoke yesterday, who is the 2021 president of APA, and all the initiatives that she put forth, the apology for racism, the resolutions for health equity, and seeing that come through this committee and the work that's being done, including advocacy and policy efforts that are access to healthcare in general, but mental health being part of that, not not a supplement, but part of healthcare. Mental health is healthcare, and that's going through at these policy levels at the state and federal level is just really incredible. So I think those are some of the things that make me excited.
Wonderful, thank you so much. And then Anna, this came up a little bit in your answer. So let me ask you this question. In your experience, what are the common misconceptions about mental health, and how does it impact cancer care?
Sure. I think one of the most common misconceptions is really about mental health is, I don't want to talk about it, right? I'll get over it. It'll pass. Again, what we know about stress on our bodies and what it does, the cardiovascular effects, right? The elevated pulse, elevated blood pressure, the changes in our endocrine system, and maybe insulin resistance that occurs, the adrenal glands, and all of this. We're treating not just the cancer, but we have to remember that stress plays a part, and being able to provide patients with resources that they need to help them get over that, get through it, and beyond it. A lot of times people are in go mode and they're getting through their treatments, they're done with treatment, and then that's when there's peace and there's a silence, and it's scary. Maybe you're not seeing your doctor that often, maybe it's once every 3 months. How do I know it's not going to come back? And so being able to talk to other people who feel in a similar way is very, very helpful.
Would any of our other speakers like to add to that question about misconceptions in mental health and how it impacts cancer care?
I would just echo Anna when she started this conversation, this panel that we have of talking about, I'm not a group person. And I think Bill Kavanaugh spoke to it yesterday, that we meet many, many people that come and say, I'm not a group person. And I think that's just the exposure and the understanding that there's a socialization. So everything that you just said, Anna, I think is a beautiful way to describe it, but it stuck with me that I'm not a group person. So sometimes it just takes a slower entry into this world.
Absolutely. Absolutely. And we can say, okay, well, we can send you to a talk therapist, or maybe we can give you something for your anxiety, but there's other areas of our health maybe that are suffering, and it could be isolation. whether that's self-imposed or you're really, so many people come to California from other places, they leave their families behind. So trying to find those connections. There's also financial toxicity, which can wear on someone's mental health. So being able to find resources.
And I would just echo all of that, but also emphasize the importance of stigma in mental health. It is still huge.
It's still there.
People feel a huge shame around asking for help, no matter what circumstances they may be experiencing.
Yeah. And I echo everything. I would add, I think there's a narrative that is still so persistent in the cancer world, kind of almost imposed. I don't know where it comes from. Hallmark movies, I don't know, but that you have to be strong. You have to be positive. You have to be inspiring. You have to be a better person for all of this. And it's like everyone that I come across who is struggling with the challenges, the very real challenges of the diagnosis, always almost ends up feeling like they have to apologize for not being perfectly able to handle all of this, and that somehow it means their family doesn't support them enough, or that they, that I'm sure you've all heard. I know so many others have it so much worse, but that sense of there is one way to approach this, and it's about being strong, positive, and grateful only, rather than those are some of the things that help people to get through. And also the ability to say, this is hard, this is scary, this is unfair. I need help. I can't carry it by myself. That there's room really for both, and that's the wholeness of the experience. And I know all of you, when you meet with the people who come to you, you immediately open the space and allow for that wholeness and say, that's legitimate, that's real, you have a right to it.
Thank you. And Anna, I know you brought up this in your answer, the idea of financial toxicity, but I'm going to pose this question to all the panelists. But what strategies do you recommend for ensuring equity in financial assistance offered to families of patients with cancer?
I think screening for financial toxicity, I don't think it's being done enough. Are you having trouble paying for your medications? How are you getting to and from your appointments? Are they relying on public transportation? Do they have friends that can bring them? Are the friends reliable? All of these things. So I think asking the questions up front will hopefully put resources in place to help them get through it.
Would anybody else like to add to that?
When we devised our initial assessment intake form, it was really important to me that we ask with the same degree of consistency and give the same amount of time to the social aspects of distress that are connected to equity as we do to the psychological, as we do to the physical. So we have in our questionnaire, what are the areas of concern that you're having? Are you having trouble sleeping? Are you having trouble with pain? Are you having trouble with anxiety? What has been the way that you've coped in the past? What's worked? What's not worked? And we ask every single one of those things you said, Anna, in that same matter of fact, like this is just as important and no more stigmatized. Are you having trouble with transportation, with finances, with housing, with social support? Are you fearing stigma at work, right? If we don't, like you said, if we don't ask, people can't tell us. And if we don't know, we never understand both the individual impact of those problems and how significant they are on a global societal level, right? Like there's so many of those things that are, childcare is one of them. it's a societal problem and it impacts individuals. And if you're going through cancer and you've got to be someplace getting your treatment, it's a problem.
Yeah, and I think that's also an opportunity for all of us in the cancer care arena, right, to actually have these social risk assessments. And then how do we use them? Do we have a system where we can do risk stratification and segmentation, right? Do we have those tools, especially smaller community-based organizations, right, to be able to do that so that we can incorporate, demographic, social determinants of health and race and ethnicity data, so then that, we have this complete understanding of the patient's needs and, including their health equity needs and addressing, like maybe providing some sort of case management, for those that show that they have these needs. So I think that's an opportunity for us. And I mean, like I said, specifically for our community-based organizations, and how do us larger institutions support those smaller ones to be able to provide them with that information? Because, data collection can get expensive in these tools. And, there's a lot of, proprietary tools that, can be costly. But I think definitely that's an opportunity for us to work more towards that social risk assessment and what to do with the answers. Anybody would like to add?
With cancer, like so many things, it can too often end up defaulting to the individual level to figure it out, to advocate, to get all the ducks in a row. And for some people that's possible, and for other people, when the structures of inequity are much more difficult, it can't just be solved on an individual level.
Okay, so that being said, Dr. Ahmed, we have a question for you. What has been the caregiver burden, particularly for the elderly, during COVID and beyond?
Yeah, absolutely. I think COVID introduced that element of isolation for everyone, and caregivers really need to be able to have respite. They need to be able to get out of the house and take a walk, talk to a friend, get exercise, whatever that is. And COVID made that very challenging, especially if they are caregivers, somebody with cancer who's immune compromised. So the risk of going out and coming back with what for them could be a relatively mild case and for their loved one is going to enormously impact their health, really scary. So we understood that these were two vulnerable populations, the elderly and caregivers, and immediately began online support groups specifically for caregivers, and we paired it with learning self-compassion, able to get many more people than we would have, if we were doing this in person, and people from a wide geographic area, and that sense of community, really, we were, as best as we could, able to create it on a platform that maybe could not have happened if we were doing it in person.
Thank you. And I know that, we've, in your answer now and, the previous one, we're touching upon the social determinants of health, right? So what do you all think, how do social determinants of health affect cancer outcomes?
It's significant. I mean, if someone is struggling with transportation or doesn't have money to get to and from their treatments, their care may be incomplete, or they might miss a cycle here, or their next cycle is late. They might not have the money to buy their anti-nausea meds. I had a gentleman who was driving about 150 miles every day to drop his child at daycare, go to work, go back, pick up the child, and then drive. I mean, it was such a challenge. And so being able to recognize that, offering support, it's really the best that we could do.
I was going to add as well, and I don't have the full details, but at a conference I recently attended, learning just what those disparities can look like at the zip code level when we have advances in medical technology and some incredible new systems for radiation or for other types of treatment. It doesn't mean that it's getting to the hospital or to the care provider that's in the area where that person lives. And so even as technology comes forward, how far behind? So to that systemic component, it's still here, it's very real. And how do we get access to not just care, but quality care and then the most advanced care? And I think we see a lot of disparities there. So, and that's just one piece of it. I just wanted to add that.
I couldn't agree with you more, Shannon, and thank you to Anna. There are so many facets to social determinants of health. I know for a Medi-Cal recipient, the kind of cancer medication that is available to them for treatment is going to be very different for the patient who A, has the ability to pay, or B, has better insurance coverage. That is going to make a huge difference in terms of their health outcome. And I wish there would be a way that could be equitable. I don't understand why the Medi-Cal patient cannot have access to the same medications, particularly when you're using the same formulary. So that, continues to really baffle me. But I'm hoping, as we continue these discussions of health equity and as we begin to look at policy changes and have a department or office of public health equity, these are the issues around social determinants that can be remediated.
Well, I'm going to leave you with this comment that was left by one of our participants. A participant who is Hispanic commented how helpful Cancer Support Community Los Angeles has been in her life, as her physician had no bedside manner while she was in treatment, and she learned much from her involvement with Cancer Support Community Los Angeles programs. So just a little bit of what the impact does on some of the programs that you are all providing. I know that sample was specific to the Cancer Support Community, but you are all, here sharing about the wonderful programs that you're doing. And I think your conversations were very insightful, but I think we're just feeling a little better knowing that there's people like you out there and there's programs that you provide out there for people, who need it. Because I know sometimes we focus on the fact that there's so much need, but we're also so grateful that there's people like you putting on these services and providing them for our communities. And with that, I really want to thank all our panelists today for our roundtable speakers. So thank you to Yolanda Whittington, thank you to Dr. Kauser Ahmed, thank you to Ana Rocha, and thank you to Dr. Shannon Cava for joining us today and sharing those inspiring messages for our participants. And just because, the Q&A is over doesn't mean you can't still, send questions, to info@cancersupportla.org in case, you want to get a hold of any of these wonderful speakers. But for now, we're going to take a slight break for 10 minutes, and we're going to invite Dr. Shannon Cava back to do her talk, and we will all be back at 2:30. So thank you, everyone. Welcome back, everyone, from our little break. And I just want to remind everyone that if you registered for continuing education credits as a mental health care provider, to please keep an eye on the chat room for attendance instructions. And now I'm going to introduce our last speaker for today. And we have back the pleasure of having Dr. Shannon Cava, who is a clinical psychologist specializing in psychosocial oncology. She's also the Chief Clinical Officer and Director of Programs and Research at the Cancer Support Community Los Angeles. Her research interests focus on multidisciplinary engagement to address health inequities and support the psychosocial needs of pediatric, young adult, and adult patients and caregivers. She is the current chair of the Health Equity Committee of the American Psychological Association and an active member of the American Psychosocial Oncology Society. Dr. Cava has engaged as a community advisor and co-investigator in research collaborations with the American Institute for Cancer Research, the Kauser Foundation Research Institute, and Providence St. John's Health Center, Cedars-Sinai Medical Center, and UCLA Center for Cancer Prevention and Control Research. So please welcome Dr. Cava.
Thank you, Myra. Wonderful to see you again. So hi, everyone. Thank you so much for joining the talk today. So I am going to be talking about thinking outside of the box, and this is really about utilizing multi-system partnerships to design models of care that can be inclusive for individuals, for us here in LA, and for you anywhere where you reside. I have no financial disclosures, and I'm going to start off today to talk a little bit about myself. So bear with me, we're going to go through some photos. So this is a photo of me when I was very young. This was actually my first day of kindergarten. I'm there with my mom. I'm an only child, and I had a sense of adventure and independence and wanted to ride the bus. So that is what I did. I think that piece of independence and a little bit of thrill seeking may have stuck with me. And it wasn't until later in life that I realized the impact that that had on my mother and my family, as this was one of many slides of the bus pulling away. So this is my likely 7th grade photo, kind of represents my awkward years. I found this not long ago, actually, my husband did, and it was broadcast out to the family through text messages and has become my Spicoli photo, if you know Fast Times at Ridgemont High. But then, oh, look at this, some of my awkwardness continues. This is me with a recent broken arm. And it might be a little silly that I'm showing you these, a little bit puzzling, but I will give some explanation of why I started the talk with these photos. And we'll put those pieces together as we get into the presentation. In terms of learning objectives, this is going to be a place where we can talk about positionality statements, conducting one's own health equity assessment for themselves personally or for their organization, listing values of partnering with multidisciplinary teams and community-based organizations, as well as utilizing models of care that already exist to create partnerships, learning from what we already have. Okay. So we're going to look at community partnerships to start there. And this is a slide that I had last year. Actually, I had the opportunity to speak at our inaugural Health Equity Summit, and we really looked at different styles, different types of partnerships, being opportunities for collaboration when you're discussing partnership across disciplines, as well as departments, as well as multi-institutional or across academia and community-based organizations. So there's so much opportunity. And where we left off last time was to look at what evolution might look like in terms of community partnership. With a lens of health equity, very appropriate to our talk today, it's how can we collaboratively engage with communities to revolutionize supportive care for families facing cancer, and do so with an inclusive and targeted support while enhancing the value across the entire healthcare system. So this was where we left off, and I think that's where we're going to start today. So a little focus on community-based participatory research. So I want to look at CVPR as just a little bit of a foundation when we start talking about partnerships. And the reason being community-based participatory research, it's a partnership approach to research that includes the researchers as well as the community stakeholders and equal partnership throughout the entire research project, including the research question. Is it meaningful to the community that's being studied? And the reason I wanted to start here was the center of this circle. So while this actually shows the 7 core components of CVPR, being accessing the strengths of the community, designing interventions and policy around the community, getting a feedback loop so there's consistent monitoring, all of those are included. And at the center, it's maintaining, sustaining, and evaluating the community-based participatory research partnership. So how does the partnership start? How do we monitor it? How do we correct it if there's any hiccups or any moments where we need to make some recommendations for change? So the 12 dynamics of this group process and partnership is listed here. Membership, who's in the group, who are you partnering with? the equitable participation and communication, establishing norms for working together, trust, and we're going to really talk about that today. Selecting and prioritizing goals and objectives, identifying the strengths and the concerns of the community that you're working with, leadership, power, influence, addressing conflict, making decisions, and coming up with strategies to work across diversity. And again, that partnership assessment, continuously monitoring the relationship. So right here, I think would be a good time for us to take a pause and really do a little bit of an activity together. I'd love for you to think of a mentor, somebody that you've looked up to, somebody that has helped you get to where you are in your career or in your position right now, even if you're in academia. And think of that person and see what kind of characteristics come to mind. So think about possibly even a partnership in your work relationship or your academic relationship. Who are your mentors and esteemed leaders? As you think of this person, what qualities are you seeing? How did you feel when you were working with this person? What characteristics of this person resonate with you? And what do you kind of want to emulate? What attributes? What do you already emulate from your relationship with this person? And now think, how can these characteristics support your collaborative goals? So some items that might have come to mind are, were they a good listener or a sounding board? Were they flexible? Was there resiliency in your relationship or how they were as a leader or mentor? Did they value a diversity of perspectives? How knowledgeable were they and how did they share that knowledge? Were they non-judgmental? Were they able to give constructive feedback? Feedback that you felt that you could take on and implement in your own change and growth? Were they honest and candid? And were they able to network and find resources? So there might be many other attributes that came to mind as well. So you can consider those as we move on to this talk. So next, I think we can look at leadership. And this information actually comes out of a study that was from 2020. So this is kind of a response to COVID. The article was co-creating a thriving human-centered health system in the post-COVID-19 era. And what really came up from this was leading change by applying the qualities of a good mentor leader into a collaborative relationship, thinking about how we can take this into our collaborative relationships. But what they focused on was the workforce well-being and burnout prevention and how that is influenced by organizational and leadership practices. And with COVID-19, how were those practices impacted by COVID? How were they changed by COVID? And how did they respond? So in terms of the pandemic or even other kind of crises across leadership, across organizations, there's this ability to either respond with a culture that might lead to stress or more difficulties and also post-traumatic growth. So coming out of this crisis, there's different opportunities to come out of it in a growing sense of how to get past that trauma. And I think that comes through this leadership model. Strategies include attention to structural and technology breakthroughs, focusing on relational and cultural leadership strategies. What kind of strategies were in place, are in place, and how can we come from responding to a pandemic to going into the what's next components that we're in right now, and what is the leadership going to look like? And maintaining the presence and creatively connecting with your team. So a lot of this is the internal culture. What do we have control over our internal culture? And again, looking at this of how we can lead change and apply the qualities that we considered in the mentorship exercise to be a leader and to be able to be part of the collaborative relationship in order to do this work together. So going from that to the idea of a closed mouth is never fed. This is something that I actually heard from my husband years and years ago. He told me this and it stuck with me, it resonated with me, and it actually helped me through my going back to graduate school, to be honest. It's making relationships because I took the risk of asking for help and really connecting with others, because not asking for help, it's really hard to make that same progress, but being able to be a little bit vulnerable and saying, would you be able to be my mentor, or can you assist me with getting connected, or how do I learn, or what can I do next? Those are ways to enter into, I think, stronger relationships and stronger work goals, but also partnerships. This comes from the American Medical Colleges, the Association of American Medical Colleges. And to give a little bit of extra impact to the idea or the value of partnership, they've determined that if you design a partnership with the element to share expertise, to share resources, to take responsibility with communities for achieving these shared goals, doing this together, that's how we can lead to the idea of community-based service learning, community-engaged research, and community-driven health services. And each of these things can be done so with trust, mutual respect, cultural humility, and mutual benefit. I might add even some of the characteristics that we decided were important to us when we were looking at that mentor, and even to those earlier discussions of trust. All of this together is going to have an impact on public health, because the whole goal there is to ensure the health of all. So coming out of the idea of working with the community, I started doing a little bit of digging, and this was just a really quick Google search, and it came with accompanied by, and it didn't have as much of an active feel as I was looking for, and I was also surprised that it went right to drinking. So then I also jumped into the Merriam-Webster definition, which is a participant in an action. And this, I feel, kind of gives us a good foundation to move on to our next topic, which is conducting health equity assessments. So this is the health equity assessment tip sheet for mental health providers. It's very appropriate for all types of providers and those that are not even in the mental health or health services. It sets the stage for an equitable partnership, but it also gives us all the opportunity to take action steps in the work that we do to provide more equitable services and care. I believe somebody will be putting this URL into the chat, so you can wait for that. It's coming, if not there already. And you can access this because this is, I think, a 4-page PDF that you can download from the APA. But to go into it a little bit, it's mental health professionals are in a unique position to inform, educate, promote health equity for healthcare. So I want to thank you all for being here today and through the 2 days that we've had this Health Equity Summit. And I think this has really shown through all of the presenters the importance that we have, the platform that we have, and how we can influence change. And I think that change can really start by taking a look inward. And this will give us some tools to do so. And a health equity assessment, if you are looking inward, it can really start to uncover policies or procedures or decisions that might be in place that can contribute to inequity. And how can we shape those to be more equitable in our practice? Another component here is looking at the social determinants of health. And if you were in our just recent roundtable, you might have heard us talking a little bit about that. One of the questions was, how do the social determinants of health either exacerbate inequities or lead to inequitable services? And this is a little bit of how we can look at that. So a quick idea of social determinants of health is these are the conditions or environments that people were born, where they live, where we learn, work, play, worship, age. So if you can get an idea of our social determinants of health, it's really everything around us. So sources of inequities can vary across the different socioeconomic status, culture, ethnic populations. You can look at the overall health and quality of life as it's influenced by the social determinants of health. You can also see where there's some worsening of health outcomes due to the social determinants of health, or those areas where people might live or work or play. An additional component to the tip sheet is also some questions. So where do you start? You can start from the beginning and just having access. Being here is a good step. But looking at questions in your own practices of, are your practices accessible? What are your hours of operation? Something as simple as that. What types of payment or insurance schedules do you have? All the way to some of the larger pieces of organizational policies and procedures. Do you have staff training in health equity? Do you have, that the idea of justice, equity, diversity, and inclusion, is that represented in your staffing, in your human resources, and in your education? So this is a good place to start with some of those self-questions. And then just a quick 5 tips, and this is a good place also to just kind of get the idea of where am I starting? And part of it is planting the seed and making a commitment. And I would offer that attending today and being part of this conversation is really that seed or even beyond planting that seed and making that commitment. But you can also do that self-reflection as an organization, which we gave some tools to, engage with stakeholders and community members, plan for change and implement it, and again, monitor. So just the same as we would monitor the relationships that we make and the partnerships that we make, we can also monitor and be flexible in how we look to our own organization's procedures and policies in the lens of health equity. Okay, so positionality statements. I told you we'd get here and that we would unpack a little bit of those photos that I shared at the beginning. So we're going to start to put that puzzle together. Positionality statements are a worldview, if you will, for an individual. Where are they coming from? They're also informed by an individual's values and beliefs that can be shaped by gender, sexuality, historical or geographical location, ethnicity, race, social class, faith, spirituality, political allegiance, disability, to name just a few. Each of those things are who make us who we are and also have an impact on our worldview. That's included in our positionality. In research, a position for a researcher, it might be what the researcher adopts in a project, but it can also influence how the project is conducted and its outcomes, as well as the results. So being aware of how positions may impact research and the research participants in the setting that they're in, it's the influence of insider-outsider standing, the acknowledgement of advantages, disadvantages, and implication for the process of data collection and interpretation. So there's a large part of awareness when we're looking at our positionality and then how it's impacting the work that we do with research as well as with our service delivery. A researcher's positionality is not fixed. The reflexive practice or articulating one's positionality may assist in becoming a better researcher. It's another way of looking inward, I believe, in how we present ourselves in our research and in our work that we're doing through program delivery. It's also a wonderful way to complement the work that we're doing by finding others that might have different positions that we can learn and grow together with each other. And it's also stated here that it's integral and qualitative research. And I think that's really important to say in terms of when we're conducting research that might be more inclusive to dialogues, conversations, interviews. We are in that process. So who we are is definitely going to be present in the work that we're doing in that research project. So being aware of your positionality. So as an example, I am a white, heterosexual, cisgender female with a middle-class background. I have access to economic resources and a high level of education. I'm doctorally trained for my work. And I work and choose to work in the nonprofit sector. A little bit more is part of the work that I do. And this is a lens that I use in my professional work. So this is me on paper. But I'm so much more, and I bring so much more to my relationships and collaborations. And you saw a glimpse of that at the beginning of the presentation when I shared some photos of my background and who I am and where I came from in a way. So using the concept of positionality statement when stewarding relationships, thinking of it as applying positionality statement to the authentic engagement with community and community partners, building complementary partnerships, and learning and growing from one another. Looking at the building blocks for collaboration, coming out of that and looking now to more of a human resources lens on the work that we do collaboratively, I would love to show that the building blocks really are influenced by trust, vulnerability, communication, self-awareness, and commitment. These sound somewhat familiar, hopefully, from what we've talked about before, and they can lead to how we make change, how we embrace it, how we lead in change. How we share information, how we listen. So it's a part of that relationship building. Is there negotiations or flexibility? And each of these are, I think, are stepping stones to how we can build collaborative processes and partnerships. You can see how authenticity and transparency can community engagement and collaboration. And rather than coming in as an expert, come in as equals and build something together. And this was also part of the conversation that we had in the roundtable. So the partnership there's an equality in that. It also helps to know our challenges and be open to share and learn and gain insight. So a little bit of background that I want to pull from is research standards and how they can influence our collaborations. So this is coming from the human subjects training. So if any of you have done research, you probably have done a human subjects training to be able to prepare. And this is the Belmont report. That is the ethical principles and guidelines for protection of human subjects in research. This is from 1979 and applies today. And it really focuses on the idea of respect for persons, beneficence, and justice. And to go into a little detail of why I think that matters, not just in research and why it is so important in the work that we do, but how does it influence our partnerships? So in terms of respect for persons, this requires researchers to assure autonomy and protect those with diminished autonomy. Allow those who can to make informed choices about taking part in research, and by instituting and adding protections for those who do not have the capacity to decide. So in diverse communities, this can be accomplished when information is tailored to subjects' linguistic needs, as well as comprehensible and delivered in a culturally congruent manner. So can you see the thread of pulling that from research into the work that we do collaboratively with community partners, with academic partners, hospital systems, all to the goal of working with the larger community to improve access to care. The other components with regard to beneficence, it requires favorable balancing of risks and benefits. Those risks including physical, emotional, economic, stigmatization we've talked about today, confidentiality. So how do you weigh that out with potential benefits? In terms of research, that would be looking at diverse communities and populations that might be more vulnerable to risk than others. But how can that apply to our partnerships and the work that we want to do collaboratively within those communities? I think you're going to see that as well. The same as researchers, those that are in service delivery would also engage with community leaders in the process of estimating risk and benefit ratios, but for service delivery, possibly needs and getting a needs assessment. So we're not coming in with the answer. We're not coming in as the expert. We are listening and hearing what the needs are and accommodating when and modifying where appropriate. And then justice. So for the individual, this requires fair recruitment practices. Social justice requires decisions being made by researchers in the light of the ability of certain ethnic and economic classes to bear added burdens of research. So consider how this might also affect our community collaborations. And as a caution, it's required in research that trust should be the first step for interventions and practices. Trust, I believe, would also be the first step in how we partner with each other and our communities. So additionally, these same considerations apply to our partnership and service delivery, looking at the involvement of community members in any decision-making. This is also with regard to promoting feelings of ownership within the community when coming in and providing a service, hearing from the community and looking to our partnered organizations of what matters to them and what their mission is as well. Maintaining public accountability and transparency, assuring appropriate ethics oversight, and building trust in the community and among starting participants. Additionally, with regard to research, it's how do you disseminate results? I think this is something that community-based organizations may know very well in terms of how to support that dissemination of findings through educational talks. We do that a lot here at Cancer Support Community Los Angeles. So sharing findings with stakeholders, peer-reviewed literature, so you're getting published, but that educational programming, how can that arm be where everything that is evidenced in the lab or in the research world can get to the community and to those that would be impacted by the study results. Again, it's about that multi-directional benefit. So I want to take a moment here to look at some models that are already in existence across healthcare and oncology care. So first up, this is overcoming barriers to collaborative care. So this is outside of oncology, but it does illuminate models of partnership in healthcare. And it was a phenomenological study of medical providers, specifically 18 medical providers from diverse settings. And they were interviewed about their experience in collaborative health care settings in which the mental health services were integrated. So this was a phenomenological approach, and 5 themes emerged that really kind of showed the benefits and barriers to delivery. And those were time and resources, proximity and access of collaboration, collaborative mental health literacy, stigma, and finances. So looking a little to stigma, that's the impact of mental health stigmatization as a barrier to accessing care. However, for this, the medical providers identified that working in collaborative health settings reduced the barriers. It gave immediate access and the stigma was reduced. This also applies, we were benefited by Anna Rocha talking a little bit about her collaborative model at Providence St. John's in the last roundtable. I think this really shows how having that collaboration can be a reduction in terms of the stigma to mental health and other services. Additionally, the benefits and barriers were linked so that the benefits actually might have mitigated the impact of the barriers on each theme. There were 2 that had exceptions there, and that was barriers related to the availability or scheduling with the mental health providers, as well as the financial barriers. I would say a lot of times in terms of collaboration and partnering, we are a community-based organization here at Cancer Support Community, and our services are free. So sometimes those barriers can be reduced by getting someone connected to a provider that is at no cost, that comes from the nonprofit sector, as well as kind of improving access and widening the net of providers by partnering with those that might be able to provide services. So in terms of conclusions and recommendations from this study, healthcare settings that offer multidisciplinary cohesive care demonstrate improved treatment continuity and patient outcomes. And this was for both physical and mental disorders. And collaborative healthcare approaches improve provider and patient outcomes and access across diverse clinical settings in an overburdened system. So these are results that I think are useful in how we continue our talks about conducting and stewarding relationships, but getting to the point of partnership and collaboration. One thing that they came out with a recommendation here was that mental health services should be offered in the same physical location that patients seek out medical treatment. So really that integrative component of care. This is a study that is actually more in the oncology world and focuses on pediatrics. And I am actually a fan of SuperSibs. I used them a lot when I was in my early career and education still, becoming a clinician, working with children with cancer and their brothers and sisters. And SuperSibs is a national nonprofit organization, and their mission is to ensure that the siblings of children with any type of cancer are supported, honored, and recognized so they feel they can face the future with strength, courage, and hope. And this was also a phenomenological study that they also shared that many community partner research that occurs at a local level, that it's a geographic cohort, and they made a great case for that community can encompass outside of just geographically diverse cohorts. This was childhood cancer as a cohort. And so they shared some lessons learned from their partnership. And this was in partnership, it was multiple academic institutions over 8 years. So first they realized that a shared mission was important. They utilized a sibling research advisory board to really come up with what that mission was and to get their project off the ground. They also recognized the balance of research and service responsibility was important, and the involvement of SuperSibs was neither contingent on or related to the research enrollment. What that meant was that a family could access SuperSibs without any need to be required to join the research and vice versa. And then the other lesson was that they ensured sample representativeness. So recruitment through community organizations may reduce the degree to which the sample resembles the broader population under the study. They also came up with the second question that were families who enrolled, did they actually resemble those who declined? So those are some ideas to go into future research. But the recommendations that came from this, and I think this is also great for community groups or researchers seeking to establish partnerships. So looking at it from that way, there's encouragement to identify partners that are committed to establishing empirically supported community-based initiatives, to develop shared goals, to use goals to inform a partnership mission, short or long-term objectives, and strategies, to frequently assess progress and modify their approach. We've heard that monitoring piece. And then any of you that are also in the nonprofit sector, this will resonate, to identify sources of ongoing financial support. So taking what we've learned from those models and looking again to the CVPR, where they have recommendations in terms of dissemination of informing action within the community, and that the findings of any research project should inform community efforts and incorporate change at the individual, organizational, community, and policy level. All of that, I think, will lead us to how do we disseminate and implement some change. To do that, I think we should look a little bit to the definitions of these terms. So dissemination is an active approach of spreading evidence-based interventions to the target audience via determined channels using planned strategies. More so, implementation is the process of putting to use or integrating evidence-based interventions within a setting. So this is often what you'll hear from community-based organizations like CSC, some of our sister sites. We are providing evidence-based programming because we are using programming that came out or implemented from research that was used to see how these different activities or group support or different models of care are utilized in a cancer population, and the efficacy there was proven, and so that is what informs the work that we do. And then looking at reach, this is the ability of a program to engage its ultimate target audience. So both in terms of quality and quantity, are you getting the services to those that you think you are getting your services to? Are you able to engage that target audience? And this is going to impact public health. So also coming out of the dissemination and implementation research in health is the second edition that we pulled this from, is a list of strategies. So I'm going to go through these quickly because there's one I really want to put focus on today. So strategies that they did say for partnership and in terms of dissemination and implementation research is using evaluative and iterative strategies, providing interactive assistance, adapting and tailoring content, developing stakeholder interrelationships, training and educating stakeholders and supporting clinicians while engaging the consumers and the communities, and utilizing financial strategies and changing infrastructure. But you see that area in red, that's where we're going to dive into. Developing stakeholder interrelationships. And I think this really plays a role in the conversation that we're having today about partnership and about how do we work together collaboratively. So again, this came from the ERIC project, and it's the expert recommendations for implementing change. And that's inclusive of developing academic partnerships, partner with a university or academic unit. I might add community-based organization, identify and prepare champions. We do that regularly, and you might have heard me speaking about this earlier. Who are our champions? There are so many people, especially those that are on our professional advisory board, those that are community stakeholders, those that are volunteer ambassadors or patient advocates that have used our services or familiar with our services or refer to our services. Those are our champions. So really identifying who they are and maybe even preparing them with additional information about what it is that we do. And so for you in your organization, how can you consider your champions? Involving executive boards. So this could be involving existing governing structures, boards, medical directors. You can think also of community advisory boards, professional advisory boards like I mentioned. We also have a Cancer Equity and Diversity Committee here. Do you have something that is in the DEI lens that can support your work? Obtaining formal commitments, using MOUs, contracts, agreements, formalize your relationship. Promoting network weaving. This is building on existing relationships within and outside of one's organization. to promote information sharing and collaborative problem solving. This is that stewarding and getting to know each other. You might make relationships. It doesn't mean that you're going to have a partnership or a partnered event the next day, but my goodness, are you getting into how you can think collaboratively, work collaboratively, and solve problems together? Sometimes those problems are, how do I get this service to this community? And you can do so together. Recruitment, designation, and training for leadership. We talked about strong leadership qualities, using advisory boards and work groups, visiting other sites. So review what's been successful, look out there, see what's been implemented and see how that works and how they got there. Ask questions. A closed mouth is never fed. So taking all of this to kind of come to the end of our talk today, I'd really like to share through illustration some of the collaborative research and practices that we have here at CSCLA. So this is what it looked like when you would walk in our doors. I am in our community right now. We've changed some of our furniture, and that's why I used past tense. But we are starting to open our doors more with in-person services being re-implemented. But it gives a little look at our community as well as our mission to be empowered by knowledge, strengthened by action, and sustained by community. In terms of the work that we do, we provide it across 5 pillars, we often say. Sometimes I'll throw in a 6th or 7th, but we have 5, which is emotional support, looking to our group support and our counseling services. We have educational workshops, healthy lifestyle classes, social activities, and resources, which aren't listed here. And then in terms of our child, teen, and family program, we have a shadow of all of those different elements that are here for our children and teens. And again, everything we provide is at no cost. Internal culture, and I feel like this is a good space to talk a little bit about that. It really ties in the idea of how we think collaboratively, but how do we also partner internally? What are our internal processes? And I think that can look like culture. A lot of this was already here, already in existence, but tested when COVID came and tested through many events over the last few years. And what we recognized in how we responded to that internally and as staff and to each other was that we promoted acceptance, we encouraged flexibility, we welcomed vulnerability, and we modeled resilience. And this not only supported our staff, our clinicians, our volunteers, but it went out from there and how each of our staff and volunteers might have looked to those that are using our services and to the participant level. Because I think that's what we were all in this together, right? So how can we learn to support each other through that? In terms of our collaborations externally, we co-branded groups and services. We've done that throughout, but that was enhanced a little bit when we went virtual. Our education as well. When we went virtual, we had access to wider, more diverse audiences. We approached and were approached by some of the hospital systems. We were joining team meetings. We were talking about how we could be a referral and making invitations to providers to come to our orientation, see who we are and what we do, and if we are a good fit for your patients and families. We attended conferences, global conferences, even things that we might not have had access to until this virtual component came into play. And we co-branded. Almost forgot our Health Equity Summit that came out of last year's initiative to do something in terms of health equity, but also how do we take what we learned with technology and be able to provide this to a wider audience. Additionally, we had increased collaboration, meaning increased attendance. Some of our program was targeted. We might be able to do a group that was for a very specific population, but now individuals from not just around the corner or not really willing to pass over the 405 freeway, we're nestled over here in West LA, they had access. So a lot of these programs grew. Co-branding again and multi-site marketing was enhanced. We even work with our Southern California affiliates. So we have a CSC in South Bay, Pasadena, and Valley Ventura that we love working with collaboratively because we can share content and share information and share even some of the activities that we have planned so more and more people can get access to that care. In terms of recognizing strengths of programs, we built a video library around the educational services that we had in play. And we had to pivot on some elements. At the very beginning of COVID, we didn't really know that telehealth would be a great space for minors, really, and it was contraindicated at that time to have telehealth. We've since seen many young people learn because they had to attend their school daily online, but we created videos so we could have therapeutic activities for their family when they wanted to access it. Okay. This is just a snapshot of our current strategic plan, and to show you here our, like, from a wide lens, the 30,000 feet look, I guess, our goals are to expand impact, build capacity, engage communities, and to do so in a fiscally responsible and sustainable way. But I would like to dive in here to the goal 3 of engaging communities, and that's increasing access and delivery of high quality, high value services and educational programs to communities in need. And pulling out from this the idea of stewarding relationships and doing it so with a framework of justice, equity, diversity, and inclusivity. This is across our program development and also across all of our strategies. What does all that look like? We have a Cancer Equity and Diversity Committee, a professional advisory board. I think CSC is very proud to be participating on advisory boards from some of our healthcare systems in the area. We are on the Community Advisory Board of Cedars-Sinai, the Community Outreach and Engagement, CAB at City of Hope, as well as the Clinical Trials Equity Advisory Committee at UCLA Johnson Comprehensive Cancer Center. And I would encourage you, if you are able to build a committee around the work that you do, I think it's highly impressionable on all of our services. For us, it really informs the work that we do. But being a part of another committee too, it's a place that you can share what you know, but learn from others and really start to network and work with other organizations and entities that are in your area. A snapshot here of just how we are looking to provide across different populations and make sure that we have services tailored to those needs. And again, if you were able to attend our roundtable, we talked briefly about our HEART initiative, which is healing equitably through action, resilience, and teamwork. And that is a great way to partner. And these are some of the incredible organizations that we're partnering with under that lens. So before we end, I know I have about a minute left. I'm just going to go through quickly some of our flyers and materials for some of our partnered activities that we do and programs that we lead. This is our Sister Friends partnership. So you got to meet Yolanda at our roundtable. So we have our Black Women Living with Cancer group here. We do Frankly Speaking About Cancer, which is from our headquarters, evidence-based programming that we can deliver here at the local level. The Cost of Care we did in Spanish. We have a lot of other programs coming soon that we do in partnership with Adventist Health White Memorial in Spanish with this same Frankly Speaking background. In partnership with our sister site in Madison at the Gildas Club, we're doing a young adult game night to meet the needs, the social needs of young adults living with cancer and their caregivers and families. And this has been very successful. It's once a month and it's an incredible trivia night. Highly recommend if you want to share it with your patients and families. We were recently invited, and I want to thank Dr. Ora Cooperberg and Shu, this photo is here. We joined the USC Adolescent and Young Adult Cancer Program at the zoo to do the Zootopia family event. And myself and 2 of our clinical associates were able to attend and provide a therapeutic activity for the kids and teens that were there. Digital Sherpa is a program coming out of our headquarters as well, where we partner those that are in service as volunteers, maybe from some of the local colleges, with maybe some of our older population that are looking for some assistance with technology. So it's a great learning experience as well as social experience, and it's intergenerational. This is a clinical trials program. Actually, this is with Dr. Maria Garcia Jimenez, who is with UCLA, and she's doing a program here, and it's being all translated into Spanish to be able to provide education around clinical trials to those at UCLA and all of you, and as well as CSCLA, and I think it's going to go even beyond there. This is her pilot. The last to share, and this is just to show how you can even broaden those collaborations. This is a partnership between Cancer Support Community Los Angeles as well as St. John's Health Center, and it's with the generosity of Tower Cancer Research Foundation. This was a consortium. So there was those three partners, yet we invited leaders across Los Angeles in different healthcare systems and different organizations to be part of this consortium to learn how we can put together a training and resource for individuals that might be a mentor to cancer caregivers. So with that, I have come to the end. This is my contact information. Please reach out. I want to work with you. I want to meet you. And I'm really grateful for your attendance today and your attendance at our Health Summit. So with that, I thank you. And I think we have Myra coming back.
Yes, thank you so much, Dr. LaCava, for that talk. And even though I've heard it twice, I still learned something new from this one, right? I think you kind of just pay attention to different parts of it. So I really appreciate it. Now, my first question to you is that I know you're talking about CBPR, and that involves including community-based organizations and or advocates to be included throughout the entire research process. We also know that now NIH and other agencies are now often requiring the involvement of community-based organizations and advocates to be included in grant proposals. Now, what suggestions do you have for researchers on how to engage community-based organizations and advocates early on in this process? Because we don't want it to be an afterthought, which sometimes it is.
It's sometimes an afterthought, and we're okay with that too, because it's a first step at engagement and getting to meet one another. So in terms of how to start at the very beginning, it's that closed mouth is never fed. If there's a potential partner or an idea, just reach out. I think there is a lot of organizations like ours that would be really interested in partnering, or at least being a community advisor on a research project or a recruitment site, or or even to the smallest element. Can we talk with you for an hour to get your ideas if we're on the right track? So I think just reaching out. And then in terms of what it looks like, sometimes I want to say afterthought as gently as I can, but I don't know that it's so much that, but just all of a sudden, whenever that idea comes of how to include the community or a community-based organization, it's doable. So we have some partnerships where we might be involved after the design and at the recruitment stage or even the implementation stage, but can we assist you in finding participants for your studies? But the big one, and I mentioned it a little bit today, is education, because one of the biggest factors about utilizing community-based organizations in your research design, as well as through any part of your research, is how are you disseminating your results? Because you don't want to do research in a silo. You want to be able to have something that's going to make an impact. And I think that's what partnering can lead to. So a lot of times in terms of our education, it's bringing in a provider that has a research project that they're about to start to say, this is why we want to do this project. This is the evidence that supports the fact that we put this together, that we're going in this direction. And then at the end of a project, what are their outcomes? And how do they report that back to the community? So that, I think, is something for us and for other community-based organizations to be probably an incredible liaison between here's where we got the data, this is the lab, and this is the end user, and how can you utilize some of these community-based organizations to make that connection and kind of connect those dots.
Yeah, I think that's a wonderful point, right? And research goes from bench to bedside to community, and it's that translational part that sometimes becomes, kind of stagnant. And so that's why it's so important to be engaging with community-based organizations and advocates to make that transition a little easier. So like you said, to disseminate those findings, to get that out there. So, especially when it's something that could, immediately make an impact and get it out there as soon as possible. So thank you for mentioning that. Now we have a question that came in, and it's asking, what is the most important lesson you've learned from engaging in community-based participatory research?
It's challenging and it's rewarding, I would say. So in terms of my engagement, I had the opportunity to participate in the Quick Start training program, which is a wonderful way to learn about community-based participatory research. I know they're based in California, and they're actually, this is just a side note, funded through the tobacco tax, and it goes through the California Breast Cancer Research Association. I've lost the last part of the acronym, but it was an incredible training. And what I learned from it, I think, impacts what I do in terms of all of the work that I have here at CSCLA. I would say that the challenge of it is that there's a lot to, I mean, it is an incredible model. CBPR is an incredible model to absorb and to kind of really understand. But when you get there, for me, it was a way to kind of put that lens on in all the work that I do with communities, that idea of trust building, that a way of coming authentically. I showed you all these silly pictures of myself because I wanted to say, we show up who we are. And I think we have to have some vulnerability as we engage with each other and with communities, and show that we're able to listen and learn from those that we are working with too. So I think that was something that I learned when I got past the initial shock of what the model looked like, but then how does it resonate with me? How does it impact me? And how can I be an assist to those that are working, not just in community-based research, but just in any type of research, to ensure that they're able to get that connection to the community with whatever kind of model of research they're utilizing.
Thank you so much. Now, our next question is asking, what advice do you have for identifying community collaborators within our healthcare system?
Ooh. So I would say wherever you start making connections, I think that can lead to the next. So I guess it's the idea of networking, dare I say networking, but I really valued my first invitation to attend either an advisory board or advisory council. And then you have access then to all of the other attendees that are in likely some similar situation, or you all have a shared mission or vision, right? So you have now expanded your circle and reach out to those, ask for the roster, see how you can connect, introduce yourself, and then that can grow. So I think there's an exponential growth when you start looking at how you can reach out. And again, you don't have to come. This is what I've learned. I'll speak from my own voice. I finally got this comfort that I didn't have to show up with this is the idea, this is the plan, this is what I want to do. So that initial meeting can be I just want to meet you. I want to show you who I am and what we do. And then maybe there's some action steps at the end of the call. And that can be what's next. What can we do together? But I think thinking maybe smaller at the beginning, so that, again, that idea of building with someone else. It's not hey, we have this, can we plug it in? But it's more of a joint process.
Yeah, I definitely agree with you. And I think, it's a very important point that you have to start somewhere. And I know those social networks are very valuable. And I think, we had a program for the Breast Cancer and the Environment Research Program where we had a community leadership committee made up of different organizations and women, throughout the Los Angeles area. And, what we're looking at now is at the social networks that were built within that committee, because, there were some partnerships that happened outside of that initial project. And it's something that just happens organically, right? It's just, you don't even have to try. It just kind of happens. A couple organizations then partnered with some researchers to do other research. And it all stemmed from, like you said, participating on that advisory council, on that committee, on that board. So thank you for sharing that. Now, we are at the end of our time. So I know it went by pretty fast, even though it was 2 days. We're so grateful we could get in so much information in 2 days for people. And we want to thank all our attendees today for joining us. And hopefully, most of you attended hopefully both days and learned from all our wonderful speakers and our panelists and our roundtables. And we really want, to welcome you to, look into all the resources and services that the cancer support community has for everyone, and including all the organizations from our speakers as well. There were some fabulous tools and resources that were provided, and hopefully you do seek out more information information and build those social networks. Like Dr. LaCava was saying, this is a great opportunity right now. Reach out to some of our speakers, try to connect with them on LinkedIn. I know I was looking up some people and I was like, oh, I need to connect with them. And so, find those ways to connect with those speakers, because that's the whole point of health equity, right? We can't all do this alone, and it's building these collaborative efforts, to help us achieve health equity. But with that being said, we really want to thank you. We hope you join us again next year when we hold our Health Equity Forum again. And we want to thank all our speakers. But, from us, just thank you so much and have a wonderful weekend.
Thank you, Myra. Thank you, everyone.